Okay, thank you. We'll start in about one more minute. We'll let everybody get settled. Testing, 1, 2, 3. Can everybody hear me okay? Can I be heard on the far corner? Jose? Okay? Good morning, everyone. Buenos días. We're going to go ahead and get started this morning. My name is Juan Flores, and I'm the director for La Fe Policy Research and Education Center. And we're going to start off as we did in the last day in a couple of activities that we've had since the summit started yesterday at 2 o'clock. So it may be a little repeat for some of you, but it's important because we also have quite a number of new people coming in this morning. So one of the important items of this event and anything that we do at La Fe is making sure that we're outreaching and communicating to everyone. And language is important, and we often don't take the time. So I'd like to have two colleagues, Jose and Tony, who are our translators for today, to speak with you for a few minutes in terms of the process of translation.
Hola, muy buenos días. ¿Cómo están todos y todas? Mi nombre es Antonio Macías y soy parte del equipo de interpretación hoy.
Hi, good morning, everyone. How's everyone doing today? Hi, my name is Jose Eduardo Sanchez, and I'm part of the interpretation team today.
Ahora sabemos bien que muchos de ustedes ya han escuchado ese discurso 2 veces, ya son expertos en la cuestión de interpretación, pero muchas personas apenas llegaron hoy en la mañana, así que vamos a volver a explicar cómo va a ser la interpretación hoy en la mañana.
So we know that some of you have already heard this spiel twice already, so you're experts in interpretation, but we know we have some new folks this morning, so we're going to go ahead and do the speech again so we can get them caught up.
Entonces lo que va a pasar hoy es que vamos a tener un espacio multilingüe en el cual si habla español o inglés, todo el mundo le va a entender. Así que ustedes tienen la posibilidad de comunicar en el idioma en que se sientan más cómodos o cómodas.
So what's going to happen today is that we're going to be creating a multilingual space. If you speak Spanish or English, you'll be able to communicate with everyone, and we're going to try to create a space where everyone's voice is heard.
Entonces, unos detalles acerca del equipo de interpretación. Si usted no maneja muy bien el español y el inglés, les vamos a pedir que usen el equipo. El equipo se ve así y tenemos muchos aparatos allá en aquella mesa allá. Entonces, si usted habla o español o inglés, pero no los dos, por favor, usen equipo hoy.
So a few things, if you speak only Spanish or English, if you're not able to go back and forth with both, we are going to ask you, we do have the interpretation equipment. If you haven't gotten one already, we're going to be back here, and this is the equipment we're giving out. So again, if you are going to need help in either Spanish or English, since we'll be going back and forth, we'll be happy to give you the equipment.
También el equipo tiene 2 rueditas. Esa rueda aquí es para el canal y por favor no cambien, debe de estar en canal 2. Pero esta aquí es volumen y pueden subir y bajar el volumen. Si están escuchando un idioma que entienden, pueden dejar puesto el audífono, ¿no? Pero nada más bajar el volumen, porque en un espacio multilingüe, como saben, va cambiando de idioma en idioma muy rápidamente, así que no guarden el equipo.
So the equipment right here, as you can see, we have 2 knobs. The first knob, the long one, that's going to be the channel. Please do not change that one. That's already been pre-programmed. The second one right here is going to be the volume. You can mess with this if you need it louder or softer. If the speaker is speaking a language that you understand, you can go ahead and just turn it all the way down instead of having to remove the whole equipment. That makes things easier since we will be going back and forth. That way you don't have to take it all off and put it back on again.
Ok, a veces la gente se pone muy nerviosa, ¿verdad? Cuando tiene que hacer una ponencia. Entonces vamos a hacer este señal desde los intérpretes. Quiere decir, hable más recio, por favor, no escuchamos. A veces los ponentes y las ponentes no ven bien. Entonces, si nos ven haciendo eso, por favor, nos ayuda para que nos vea el ponente, ¿ok? Eso quiere decir más volumen.
Sometimes when people get really nervous, they start speaking really softly. So what we're going to do is this sign right here, which means to please speak louder. If the speaker is not looking at us or cannot see us, we're going to ask for your help. If you can also signal them by raising your hand like this, meaning to speak louder.
A veces también la gente pone muy nervioso y habla muy rápido, y no entendemos muy bien y es muy difícil interpretar porque está hablando así súper rápido. Entonces vamos a hacer este señal que quiere decir, por favor, hable más despacio. Igual, si nos ven haciendo este señal, nos ayudan a hacer lo mismo.
Sometimes people get really excited, start speaking really, really fast, and so it's really hard to interpret. And then we're going to be doing this signal, which means to please slow down when you're speaking. And again, we're going to ask you if the speaker cannot see us, if you could help us out by making this signal, signaling them to slow down.
Si su aparato no funciona, no sufran en silencio, levante la mano, vamos a cambiar el equipo por cualquier motivo. Por favor, les pedimos que no hablen todo el mundo a la vez, porque nosotros tendríamos que privilegiar una voz sobre otra. Y todos queremos que todo el mundo se escuche. Entonces, una persona a la vez. Y a veces también tenemos esos complex border identities y hablamos en English and Spanish at the same time a la vez. Y nos cuesta un poquito como intérpretes, ¿no? No es decir que eso sea malo, ¿no? Obvio, si quieren hablar en Spanglish, todos tenemos el derecho. Pero nos cuesta un poquito, así que un idioma a la vez, por favor, también.
So if you're having a problem with your equipment, please do not suffer in silence. Let us know and we'll help you out. And also, please speak one person at a time. When various people are speaking at the same time, that puts us in a difficult position to have to privilege one voice over the other. And also, we know we all come from very complex identities. A veces empezamos en español and then we change to English. Y a veces es un poco difícil to try to, speak in one language. And, there's nothing wrong with that. We can speak in Spanglish or English and Spanish, but we do encourage you to speak if you can, in one language. That way it is easier for the interpreters to get your message.
Entonces, muchísimas gracias. Un espacio multilingüe se construye entre todos, ¿no? Entonces, ustedes están llevando la misma responsabilidad que nosotros. Les agradecemos mucho su comprensión y su tiempo y su ayuda en la construcción de este espacio hoy. Gracias.
So again, many thanks. Multilingual space is constructed collaboratively, and so we are sharing the responsibility with all of you here today to do that. And again, we thank you for your time and for participating. Thank you.
These guys have really been great. Again, I want to welcome everyone here this morning from Lafayette Prec, Lafayette Policy Research and Education Center. The name speaks for itself as to what we do, but I think more important for those of you that started with us yesterday at 2, and then those of you here today, what you see is how we do it. And that is, regardless of any information, any policy research, it comes down to what people in community feel, what they value, and we try to connect that information and connect it from them, not just something that we collect. La Fe PREC is part of Centro de Salud Familiar La Fe. That's our parent organization that's based in El Paso. And I'm sorry that our CEO, Salvador Corta, couldn't be here to welcome you. He's just restricted from travel because of a broken ankle. In addition, I thank you for being here on behalf of UTSA, the College of Public Policy in particular. And I want to thank in advance because it's always easy to pass by, you get busy and you get your program going. But I do want to introduce Amy Caso, our senior policy analyst that many of you know has been working very energetically on this agenda. And especially, although I believe she's outside, most of you, she's probably had more communications with most of you, and that's Pat Medina, who has done a lot of work in helping us coordinate and keep things together. So I appreciate my staff very much for what they do, and above and beyond the call of duty, to say the least. I want to mention a few administrative things. I think most of you know now, as you walk out the door, the first hallway all the way down past the clock are the restrooms. We're not going to really have any formal breaks. Feel free to get up and take a break. You want to grab some water, some juice, by all means, because I know we're going to have a very challenging agenda. I also want to express our gratitude in advance to our sponsors. And again, UTSA, the College of Public Policy, has just been exemplary in partnering and collaborating with us and allowing us, if we could give them applause, thank you. You know, the use of these facilities, and so we appreciate it so much, and their staff and their crew. You know, the folks that have set things up have been amazing, and we appreciate it very much in working with them. I also want to express appreciation to folks that maybe not here, but they're in the they're in the scenes, and they contributed for the cost of the event. For example, the Center for Social Inclusion, that's the executive director is Maya Wally, and they're based in New York City, provided us funds for this. We've worked with Maya and her crew around issues of race and ethnicity and issues dealing with barriers and inequities in access to health care. And they're excellent trainers and excellent advocates. We thank NCLR, National Council de la Raza. Jennifer, I believe, is here as one of our panelists. You see her, make sure you thank her for also contributing and being part of this collaboration. We want to thank Lilly Pharmaceuticals, who contributed to us, and we want to thank Pfizer and very much, and Cecilia Rupert is here as well and has joined us, and they contributed. We want to thank from Boston, Community Catalyst, a group that's been around for many years, working in health advocacy, particularly around people of color. So, and I don't want to leave out the Colectiva Flatlander, and that's Tomas. That equipment for translation is expensive. There are those of you that have done this before, and they contributed that to us. And so we really thank Tomas and the Colectiva Flatlander for providing that opportunity to us. You know, why are we here? It's really critical that we understand that, and we're very upfront, and I hope the agenda that y'all received made it very clear. We want to be a more organized voice for dealing with the inequities that impact the Latino community, and we want to have a conversation about the Affordable Care Act and the opportunities that it presents. Yesterday at 2 o'clock, we had a group from across the state, around 35 folks from grassroots organizations and social and health human service agencies from the Valley and Dallas and Houston, El Paso and Austin. And they're here this morning with us as well. And they started a conversation about politics and policies, and particularly in their community. And the whole issue and the major thread was, how do we develop more power? How do we create change? All of us in this room know that we have a very red conservative state. Its history of investment in folks of color and low income is not a lot to be proud of, although we are proud of our state in other areas. And we know that it's going to take major change in terms of the political power, and we know it's not going to happen at the upcoming legislative session. But, you know, when you listen to the folks that were here yesterday, they're folks that have a lot of resilience, folks that understand what's going on in community and their neighborhoods and down to the street level. And they're not about to give up. They are about mobilizing people. They are about creating power. And that's a thread that's in here, because the changes we're talking about, healthcare, are not going to come just simply because somebody wants to be benevolent to us, okay? We know that we need to move those systems. So that's in large part why we're here. We have approximately 3.5 to 3.7 million Latinos that are uninsured in the state. Close to 60% of the over 6 million that are uninsured. We represent 60% of the uninsured, of all the uninsured in our state. And we know that while we are stressing prevention, and a lot of you are involved with that, we know from extensive documentation that fundamental access to health care is the gateway, in fact, to prevention and to keep us well. We need to all have that opportunity. And we make no bones that we feel it's a human right and not something for the privileged. So as we look at the agenda, I'll just summarize it with three basic objectives: to discuss the opportunities and political challenges to implement the ACAs, particularly in the Medicaid expansion, and a couple of other health components of the Act in our state, regardless if our governor and the conservative policymakers have expressed that they don't want to do it. To discuss the level of state effort that is going on today, and we got some excellent people, great people who have been committed to this movement of healthcare access that are joining us in our panels. And we really appreciate them being here and taking the time. And then we want to promote and expand collaboration among ourselves that are in this room, but also as the folks that you'll meet here and also are on the panels, you'll find that we have various collaborations going on across the state that we need to tie in. Some of these names you may have heard or may not, and we have some materials that are going to be out on the table. My Medicaid Matters is a coalition. Cover Texas Now is a coalition. Healthy Texas Now is a coalition. And then there's other avenues, you know, that once we can gain our strength, that we should approach things like the public hospital districts. You know, we should approach the health professionals. We should approach business. These are entities that, quite frankly, some of those elements are actually wanting to talk to our governor, and maybe they have more power right now than we do because they got the money. But we should not exclude ourselves from those coalitions as well. So as Latinos, we're not here to be exclusive. We're going to partner, and certainly with other folks of color and communities. But it's important to know where we stand. It's important to know what our community looks like. It's important to take these eyes and focus them on who we are and those issues that we encounter. We need to tell our stories as part of that policy-making process. So that's why we're here, if you will, succinctly. And as I mentioned, you know, we have materials that we hope you'll take advantage of. I want to now just shift to introducing a keynote. As you know, on our agenda, we had Senator Vanderpute, who was going to be one of our keynotes this morning. Unfortunately, she broke her ankle walking down the Capitol. You know, I don't want to say that a Republican pushed her, okay? So don't spread any rumors, all right? I had to get that plug in, okay? you know, she's our gente, ¿qué te puedo decir? And in any case, but she did, and she really did want to be here, so she apologizes for that, and it just happened. Day before yesterday, she was in surgery yesterday, and you might have heard it on the news. And she's a strong advocate around this issue, and so I just want to, again, express that to you. I want to now introduce Dr. Rogelio Saenz. And Dr. Rogelio Saenz is the Dean of the College of Public Policy and the Peter Flon Professor of Demography here at UTSA. He's also the Kersey Policy Fellow at the Carsey Institute at the University of New Hampshire. He received his PhD in sociology from Iowa State University. He's written extensively in the area of demography, on Latinos, on race and ethnic relationships, inequality, and immigration. Dr. Saenz is co-editor of Latinos in the United States, Changing the Face of America, and co-author of Latino Issues, a reference handbook. He also writes regularly for the Population Reference Bureau on an ongoing demographic trends, including authoring for the Population Bureau the updated title, Latinos in the United States 2010. Finally, he's vice president of the Southwestern Social Science Association and chair of the Council of the Inter-University Consortium for Political and Social Research. If y'all would welcome Dr. Saenz, please.
Buenos dias, good morning. And on behalf of University of Texas, San Antonio, I'd also like to welcome you here. And in the College of Public Policy, as Juan mentioned, we have been working collaboratively on trying to bring these kinds of forum in terms of bringing together practitioners and academicians and so forth to address these particular issues. Let's see if I can. So as Juan mentioned, one of the important things is that we tell our own story. Tell our own story about issues regarding health, experiences that we've had in health, in education, and so forth. And I've been doing work on the area of demography, looking at the demography of first the Mexican origin population and then the Latino population. So I've been doing this work for about 30 years or so. So when I started back in from the 1980 census, the Latino population looked tremendously different. The issues were still there: health, for example, education, housing, those kinds of issues. They've evolved somewhat, and immigration, for example, has become a much more important issue today than it was back in the 70s or so. So one of the things that I've been seeing is this transformations that have taken place in the Latino population, and I'm going to provide you that overview and also talk to you about some of the issues in the health area. So some of the major messages that you'll get from this presentation: as you well know, the U.S. population is evolving tremendously, experiencing significant changes in its racial and ethnic composition. And I always, whenever I go around the country talking about these demographic trends, I always make the argument that Latinos represent the engine of the U.S. population. If it was not for the Latino population, the U.S. population would look tremendously different. And one of the things that has been coming about for centuries and centuries in this country, when it has come to racial relations, it has been a black-white paradigm that we've had in this country. We think about race, and that is, we come from these particular lens that are black or white. But Latinos are challenging that particular paradigm and bringing a broader perspective in terms of it is not only a black-white world, but it is a multicolored world where the Latino population plays a significant role. And we'll also be talking about these demographic shifts and the health implications, and then concluding with the fact that looking into the future, where we're talking about the next few decades, Latinos are going to impact not only the health institution, but we're going to be impacting all societal institutions. First of all, who are Latinos? And here from the 2010 census, you can see all the the 20 largest groups here that form the Latino population. Mexicans continue to be the largest group. About 2/3 of the Latino population continues to be Mexican. Then you have Puerto Ricans, then you have Cubans, and then now, more recently, Salvadoreños overtook Dominicanos as the fourth largest group, and Dominicanos there. Guatemalans, another millionaire group with another million individuals. You can see all the way the great diversity, all the way to Paraguayans there with about 20,000 in this country. And if we look back in the 1960s, for example, it was a tremendously different Latino population. You wouldn't find this diversity. For the most part, you found lots of Mexicans, a few Puerto Ricans, and even fewer Cubans, and very little of other groups. So it is, we've seen a much greater degree of diversity in the Latino population. Now, I've talked about this issue of Latinos as the engine of U.S. population change. The Latino population, despite what we often hear in the mass media and from politicians, from the right, for example, Latinos are very important to this country. If it was not for the Latino population, the United States would look very much like we see European countries. European countries that are aging tremendously, that have very few youth in those particular populations. Populations that are growing very, very slowly, or in some cases, even declining in population. The U.S. population, on the other hand, due largely to the Latino population, is a very vibrant population, and we'll see some of the patterns that are going through. This is kind of an overview of where we've come from in the last 30 years or so, extending back to 1980. You can see 1980, there were about 14.6 million people. By the time we're talking about 2010, we're talking about 50.5 million people. So in other words, during this particular point in time, for every one Latino that there was back in 1980, now there are about 3.5 more of us at that particular point in time. So you can see that, and no other group in the United States has experienced this tremendous growth as the Latino population has experienced. And what you've seen is that the pace at which the population has increased has been very rapid compared to the overall United States. So for example, in the period 1980 to 1990, 53% is the growth that Latinos experienced, compared to about 10% for the overall population. And you can see the latest figures, 2000 to 2010, 43% growth, again, reflecting the decrease in immigration that we've seen the last several years. And then you can see a very steady increase for the United States, about 10%. So you can see that overall, the Latino population grew more than four times as fast as the overall US population. And what we've seen then is Latinos becoming responsible for greater and greater portions of the change in the population. So back in 1980 to 1990, of the overall growth that took place in the United States, about 35%, about 1 out of every 3 people added to the US population through births, for example, or through immigration, were Latino. Now we fast forward to 2000 and to 2010, and we can see here about 56%, so more than 1 out of every 2 individuals that were added to this country over that 10-year period was Latinos. Again, you can see the power of Latinos in this country demographically. And as a result, our share of the US population has increased dramatically. Back in 1980, 6%, so about 1 out of every 16 individuals in the United States was Latino. Fast forward to 2010, and it's now 16.3%. Now 1 out of every 6 individuals in this country is Latino. Again, a tremendous impact in a very short period of time. And one of the questions that people ask is, why has the population increased so much rapidly compared to other groups? And if we look at the demographic structure of this particular population, we can see that there are 3 key components. One, age structure. And this is probably the most important component here, the age structure of the Latino population, because this is going to be the primary component that is going to see the shifts in the US population in the coming decades, as I will illustrate in a few minutes. Immigration has played a key role also in this population change. And then what demographers call natural increase, which is simply taking births and subtracting deaths. Let's take a look at the age structure. The Latino population is the most youthful population in the United States, the most youthful. 2009, 2010, the white population had a median age of 41. Half population was more than 41, half was younger than 41. In contrast, the Latino population, we're talking about a median age of 27, 14 years younger on average. If we think of who has babies, for example, with 41-year-olds, there aren't too many 41-year-old women, for example, who are having babies. In contrast, if you look at age 27, that is really the peak of fertility. Women tend to have the greatest degrees of fertility by the age of 27 or so. So you can see the youthfulness of the population is going to have a major impact in the coming years. Demographers use these pictorial kind of illustrations here, what we call the age-sex pyramids, to illustrate how youthful or how old a particular population is. And what you have along the vertical axis is you have age groups, 5 years, 0 to 4, 5 to 9, etc., all the way to 85 and older. Along the horizontal base, you have the percent of the population, of the overall Latino population, for example, or white population, and then you have males on the left in green, females on the right in blue. And you can see, for example, that if you look at the Latino population on the left, if you look at the bar at the bottom towards the left, that would indicate that for Latinos 0 to 4 years of age, these are little children, they represent close to 6% of the overall Latino population. Now, if you compare the Latino population on the left and the white population on the right, you can see the tremendous difference in age structure. You can see a white base at the bottom for the Latino population, indicating that you have a lot of youth in this particular population. At the top, you almost see kind of a needle at the top, indicating that in the Latino population, even though there are a good number of individuals who are seniors in our community, proportionately speaking, the number continues to be relatively small. In contrast, if you look at the white population, you see a tremendously different age structure. No longer do you see that white base. Now, instead of close to 6% children 0 to 4, boys, for example, 6%, now you have boys, white boys, 0 to 4 years of age, a little bit less than 3%. Okay? So very constricted base. And then at the top, you see a much wider bars at the older ages, again suggesting an older population. And what we're going to see in this revolution has already started. The revolution has already started for the aging of the U.S. population, which is a cohort that has been affecting us, the country throughout the last 60 years or so. That has been the baby boomers that were born between 1946 and 1964. The first cohort of baby boomers that were born in 1946, they reached retirement age last year, 2011. So you're going to see for the next, up to about 2029 or so, we're going to see this tremendous growth of the elderly population alongside the workers that are going to be the workforce are going to be increasingly Latino. That's what the future is going to hold in the next 3 decades. Very much of an aging population. We're going to see tremendous amounts of aging alongside a workforce that is increasingly Latino. Now, immigration plays another part in trying to explain the rapid growth of the Latino population. And for example, if we look only at legal immigration to the United States, approximately half of the immigration that took place from 1990 to the present has come from Latin America, versus about 15% from Europe. So you can see that immigrants also come. Immigrants tend to be a relatively young population. They come as working age individuals. So again, they contribute to that usefulness of the population. And then when it comes to fertility, for example, Latinas overall have a relatively high fertility rate, 3, versus white women about 1.9. The latest statistics that have come out suggest that there has been a significant decline in fertility, particularly for the Latina population. Much of the speculations is the state of the economy, and the economy has really affected Latinos more than significantly than other groups, and that is one of the explanations that we've seen a reduction in fertility. And then mortality is the other a key role here, and many of you may not realize this, and if you see this, you'll probably say he probably made a typo here, and that is that Latino males, on average, outlive whites by 2.3 years, while Latina females outlive females by 2.7 years. The latest life tables that were put out by the National Center for Health Statistics in 2006. I'll get to that in a few minutes, into that paradox. And this particular here, going back to fertility and mortality, this slide here gives you a glimpse of where we're going to be in the next decade, in the next 2 decades, in the next 3 decades. And all of this reflects the difference in the age structure of whites and Latinos in this country. If we take a look at the period 2000 to 2009, and we look at the number of births and the number of deaths. For the white population, there were about 21 million babies that were born in the white population, and there were at the same time 18 million whites who died during that time. In contrast, if we look at Latinos, there were approximately 9 million births that took place, and there were just over 1 million Latinos who died during that particular point in time. If you look at the proportion or the ratio of birth to death, for example, what you see with whites is that there is, for every 1 death that occurred to the white population at this time, in this 9-10-year period, there was 1.1 babies, I guess plural, that were born. In contrast, if you look at the Latino population, for every 1 death that took place in the Latino population, there were 8.9, essentially 9 births. Okay? Welcome to the future of America, okay? Where we're talking about this has major, major implications for what is coming down, the way this country is going to shift. And all of this here, these tremendous differences here, are reflective of this age structure, okay? Where you have on the left Latinos. Many Latinos are very young. We know that the probability of death is relatively low for individuals who are very young. On the other side, with the white population, you have relatively few people in the younger ages. You have more people in the older ages, where mortality rates tend to be higher. So again, this gives us an indication where we're going to be, where we're headed in the next couple of decades, several decades. So you see this age split between Latinos and whites. And this has major implications for the future. And it also reflects a lot of the policy formation that we see, where we're talking about education in this state. $5.4 billion we slashed to education. We're talking about the health for the poor. The governor doesn't want to create all these opportunities and so forth. Again, it reflects who is the population that is growing fast here and so forth. A demographic harbinger here in terms of the future. In 2009, for the first time, Latino children represented the majority of first graders enrolled in the state of Texas. 2010, a little higher, 2011, and that's going to get increasingly higher in the coming years. This chart gives you an indication of the presence of Latinos and whites across different age groups. So along the bottom there you have the age groups 0 to 4, 5 to 9, all the way to 85 and older. In the orange you see the percentage of that particular age group that is Latino. In yellow you see the percentage of that particular age group that is white. So you can see that in the older ages there are many, 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 many more whites than there are Latinos in that particular population. By the time that you're talking about age 30 or so, it kind of shifts. And from 30 on up, for the most part, with the exclusion of one or two groups there, you see Latinos. There are more Latinos than whites, particularly as you get to the younger ages. So by the time you're talking about 0 to 4, 50% of all people less than 5 years of age are Latino. So you can see the future. That particular bar is going to get bigger and bigger, and that bar over at age 30, that there are more Latinos, is going to slide at age 35, 40, and so forth. So this is an illustration of this, what demographers have been talking about. We often hear in 2018 and 2022 and all this. This provides you kind of an illustration of the steps that we're going to take in this transformation. And so that it is no wonder that a lot of people are afraid of Latinos, because they see the potential power. And one of the ways in which you can curtail the power of Latinos is to slash education. Make sure that their dropout rates continue to be very high, because we know that a citizenry that doesn't have high levels of education, for example, on average, tends to be less civically engaged and so forth, less likely to vote and so forth, less likely to register. You see the same pattern taking in California, the same picture taking place in California, and the state that has been in the news a lot when it comes to immigration, Arizona. You see that particularly at the older ages, where you have a lot of migrants, older migrants moving to Arizona. So this is really the future, and where we're talking about public policy related to education, public policy related to health. These are tremendously important issues, because instead of the way that we are characterized and portrayed as a problem to this country, we really are an asset to the United States. And the future belongs to the Latino population in terms of, as Latinos go, so will the United States. And let's take a look at some of the consequences. What's going to happen in terms of the future? And the consequences that we're going to see in the next 20, 30 years, and demographers would very much illustrate that the script is already set. Okay, so like the movie producer and everything, the script is already set. What's going to happen in the next 20, 30 years? All the players have their roles and everything like that. And these are kind of the changes that are going to be coming. We're going to, just like the baby boomers impacted every institution along the lines, we're also going to see Latinos today's Latinos impacting in all the institutions. So we're going to see an expanding of the Latino population alongside a declining white population in the future, and we're going to see an expanding Latino presence throughout the United States. It's no longer a game that we find only in Texas, in Arizona, Colorado, Nuevo Mexico, Florida, New York. Now it's North Carolina, South Carolina, Georgia, even New Hampshire, even Iowa, all of these places where Latinos have fanned out into these particular areas. So the future here, just to give you a couple of highlights here, as I indicated, the script is already written. Okay, the players know what their roles are in the coming U.S. population. Population projections that were developed in 2008 suggest that the Latino population will nearly triple from about 50 million in 2010 to about 133 million in 2050, versus an increase of the white population of 2.5 million people during that 50-year period, only 1.2% increase. And again, all of this reflects back to that age structure. Very youthful Latinos and an aging white population. It is expected that 2/3 of the U.S. population projected growth that is going to be taking place over the next 40 years will be due to Latino growth, about 2/3, about 66, 67%, versus whites will be responsible for about 2% of the overall growth. So you can think of all the growth that is expected in the next 40 years, 2 out of every 3 individuals added to the U.S. population is expected to be white. On the other hand, 1 out of 50 individuals that are added to the U.S. population are projected to be white. Again, very powerful numbers, and again, reflecting the differences, a very youthful Latino population and an aging white population. By 2050, then, Latinos could represent 3 out of every 10 persons, so about 30% of the U.S. population, and the share of the white population is expected to drop from about 65% to about 46%. So you can see this demographic kind of trends in motion, and the changes that are going to be taking place in this population. Now, the Latino population is very interesting also, and let's move now to the health patterns of the Latino population. Okay, and first of all, we can start with the Latino risk factors predicting high levels of mortality. Okay, there are a lot of factors here. Low education is associated with high levels of mortality. Low income is associated with high levels of mortality. Many work in dangerous jobs. This tends to be associated with mortality. We also have the lowest health insurance coverage, which tends to be associated also with health and mortality. We also have high obesity in the Latino population, which tends to be associated with mortality. And we also have high levels of diabetes. These are some of the risk factors. So you would predict very high levels or relatively high levels for the Latino population. Let's take a look at the reality. These are data from the National Center for Health Statistics, and this would be life expectancy. So on average, what would be the age that different groups would be expected to live? And you can see there on the left, you have the Latino population. Males, on average, would be expected to live. This would be a baby born in 2006, would be expected to live on average about 77.9 years. Female Latina born in 2006, expected to live on average 83.1. And as you can see, if you compare that to whites, which are in the middle there, and also to blacks, you can see that Latinos come out much more favorably. The life expectancy of Latinos is longer than that of whites, and it is longer than that of blacks. So if you look back here at these predictors that were predicting low education, Latinos have low education, they have low income, they work in dangerous jobs, they don't have health insurance, there's high obesity, high diabetes, and yet the outcome tends to be much, much different. And this is what epidemiology, and a couple of illustrations here, different causes of death. These are the leading causes of death. And you can see these have been adjusted for age differences and so forth. So these would be deaths per 100,000 people in the population. And you can see Whites have higher levels of heart disease, cancer, accidents, and cardiovascular disease compared to the Latino population. In contrast, when it comes to diabetes, more people in our community die than whites do and those figures at the bottom, the overall, again, reflecting some of the differences that we see in the life expectancy. We see it in infant mortality also. Infant mortality, this would be for every 1,000 births that occur, how many babies do not make it to their first birthday. And we can see with the Latino population, it's about 5.4, very low levels of infant mortality. The white population, it's slightly higher, 5.6. And then African Americans, it's 13.4. Major difference between blacks and Latinos and whites. But again, the case is that for Latinos, pretty much even with whites in infant mortality, despite high levels of poverty and so forth. And this pattern is what epidemiologists, demographers have called the epidemiological paradox. It's also known as the Mexican immigrant paradox because it is particularly Mexican immigrants that reflect these particular patterns. So that if you look at first generation, for example, they tend to have the lowest levels of mortality and so forth. And it is the fact that as you go up the generations, those mortality rates tend to increase. And also, very importantly, as immigrants are here in the United States longer, their mortality also tends to increase, their health tends to decrease. There are a few explanations that have been put forth. One of these concerns the migrant selectivity from the home country. And if we look at who immigrates to the United States, this is a very selective population. These are individuals who tend to be healthy, so that migration tends to draw from the healthiest segments of the population. So the argument is that once immigrants come here to the United States, they tend to be relatively healthy, and they continue to be relatively healthy, and as a result, have low levels of mortality. Another explanation is that there may be something protective in the immigrant culture or the immigrant lifestyle. Perhaps it's diet, more concentration on vegetables, for example, instead of high-fat foods and meat and pizza and all that kind of stuff. And perhaps even as simple as the corn tortilla versus the flour tortilla. The corn tortilla is much more healthy than the flour tortilla. The extent to which there is lifestyles, for example, women tend to be less likely to smoke or drink, which tends to be associated with more favorable births, for example. All of those are kind of factors that may be related to the immigrant culture, lifestyle, that tends to be protective. And that the longer that they are here, they lose that advantage as they become acculturated, start eating Big Macs and pizza and all those kind of things. And another is what is called the salmon bias, just like the salmon going back to spawn. And the argument is that what you have here is that it may be that Latinos, especially Mexicans here in the US, if they get very ill, that they may return back to Mexico, and there, if they die, their death is unrecorded. So this is another explanation. And then a fourth one is that it may reflect some methodological or data limitations. These mortality rates are computed by birth certificates, for example, or death certificates alongside census records and things like that. So there may be mismatch in the way people are identified or in ages, whatever the case may be. So these are the four explanations. And again, demographers and epidemiologists have continued trying to unravel this paradox. We see this paradox also in other countries, in Australia and other countries that are experiencing immigration. They tend to reflect similar kinds of patterns. And the reality, though, that even though we live long here, the reality is that Latinos live longer than whites, but they do so with more health problems. So if you look at a lot of the morbidity diseases, for example, that people have, diabetes, for example, and other diseases, we tend to be higher. When it comes to disability, disability is much, much higher in the Latino population compared to the white population. So that even though policymakers may say, well, we don't need to worry about Latinos because they live a long, long time, the fact is that there are a tremendous amount of problems that we tend to live longer with more health problems. And you can see this is a chart here that shows disability rates starting at very young ages to very old ages. The black line represents whites. The blue line represents native-born, US-born Latinos. And the red line represents Mexican foreign-born individuals. And you can see the foreign-born Mexican individuals, very low disability rates. Again, part of that selectivity that they come very healthy. And then you look at whites and Mexican Americans in the U.S., very similar till about age 45. Then you see much higher disability rates for Mexican Americans compared to whites. And sometimes along the lines of about 70, 65, 70, you see higher disability for Mexican immigrants. It may reflect the wear and tear on the body, the kinds of jobs that immigrants do that eventually it catches up as you get into older ages. And now I'll conclude here with some thoughts. So alongside these demographic trends that we've seen, this explosive growth in the Latino population, the buying power of Latinos has more than doubled over the past decade. The US buying power, 52% increase compared to more than doubling for the Latino population. This comes from the University of Georgia, the Select Center for Economic Growth. The $1 trillion buying power of Latinos in 2010 is larger than the economies of all but 14 countries around the world. So you have economic power here. Latino buying power is expected to increase from 1 trillion in 2010 to 1.5 trillion in 2015 versus much slower growth in the buying power of the overall US population. Latinos, if we were looking at the number of Latinos in this country, and Latinos were a country by themselves, we would be about the 25th largest country in the world. Okay, so you can see the tremendous power of this group. And despite all of these trends, Latinos continue to be seen as perpetual foreigners, individuals who do not belong in this country, despite, again, long, long historical roots and the land that we're standing in belonging to Mexico at one point in time. Latinos also continue to be ignored in much of social and political life in the U.S. It's like we're the invisible men and women and children in this country. You look at the mass media, and for the most part, Latinos are absent. If you look at the political dialogue, if you look at the Sunday morning talking heads, there aren't Latino talking heads there. Despite the fact that you're looking at the future, you're talking about 2/3 of the growth that is going to be taking place in the U.S. in the next 40 years is Latino. We're not there at the table. We're not there at the table. So when it comes to policy dialogues that Juan has been pushing forth, he's doing this for a purpose because we're not there at that table. And we've seen also the recent efforts to try to control this population growth that is taking place. And we've seen a lot of policies, including the debates that we're having in healthcare policy, that is trying to limit the potential of the Latino population. We've seen the state and local anti-immigrant policies. We've seen the attack on affirmative action. Affirmative action is only there on paper, but not in reality. We've seen the attacks on bilingual education. We've seen the massive cuts to public school education. We've seen the booming incarceration of people of color, particularly African Americans and Latinos. We've seen the political redistricting and the gerrymandering, overt gerrymandering that was to minimize the political power of Latinos. And we've seen more recently the voter ID that has been tried to push forth to try to minimize, again, the power, the Latino power. So these are the major challenges for trying to create Latino power. And the reality is that just like baby boomers affected all of these institutions in the country, Latinos are also going to affect all of these. The military, okay, who are going to be the soldiers, for example. Of course, Latinos are going to be the young force there. The business community, who's going to be the consumers, the entrepreneurs. Higher education, who are going to be the students that are in K through 12, that are graduating and going and having potential to go on to college. The political institution, the candidates, the voters, the healthcare, who are going to be the patients, for example. Increasingly, we too will become an aging population, and there will become more and more elderly in the Latino population, and who are going to be the workers in the healthcare system. The religious institutions, already we've seen a lot of movement from Latinos, from Catholic to Protestantism and evangelical religions and so forth. There's a lot of recruiting by other religions of Latinos. Again, they know the demographics. And the housing institution, the housing that is going to be needed and so forth. So as you can see, all of these institutions, not only in health, but in all these other institutions, Latinos are going to play a primary role in this. So in terms of looking at the future, we're talking about Latinos in many ways. We're talking about Latinos as the future of this country. So I'll stop now. Thank you.
We're going to move very fast, but I would like to, if you will, entertain one or two questions. And we have a mic that y'all would like to pose to Dr. Sines. Does anyone like to pose a question or two to him? He did a great job, didn't he? Oh, there's a young lady right here.
Where can we get that data?
I can send you the PowerPoint and yeah. Okay. Amy, yeah, and yeah, and a lot of that has the citations and so it says it. Yeah, yeah.
Thank you.
Okay.
You know, I'm not a researcher, so my Chicano brain takes away certain things from Dr. Sines, and there's three things that come to mind. La cultura cura, okay? El que no habla, no se oye. And if you're not on the good side of Latinos right now, you better be, because that's why we're so healthy, okay? You know, that's my theory on the paradox, okay? That's why we're healthy, comparatively speaking, in terms of long life, notwithstanding that we do have a lot of health problems, if you will. I want to quickly describe, as we bring our panelists up and begin into a question and answer, a little bit of the process, and Amy's going to help me with this. We're going to introduce our panelists first, and we will have a facilitator do that, and then they'll proceed to make their presentations, and we'd like to hold off the answers until all of them have presented, and then we'll proceed from there to take questions from each of the tables. And with that in mind, I'm going to ask Amy to kind of just go through the process for that Q&A. It's important, guys, and I hope you'll be patient with us, because I think that once you hear the folks that are going to be presenting just some really good information to help our advocacy move our agendas with the upcoming legislature, you may just have a lot of questions. And we'd really like to kind of balance it out across the tables and move our agenda as quickly as possible. And we apologize in advance if we're not able to answer all the questions. But the folks are going to be with us through lunch. There'll be time to maybe connect with them, and certainly after the agenda in terms of other things we're planning sort of post this summit. Amy?
Good morning, everyone. As you see, there's an envelope sitting on your table, and what it has is colored index cards. And each colored index card represents a different panel. And what we like to do today is, for the purpose of just being efficient, and we're going to be asking that if you, and a question arises to you that you'd like to ask one of the panelists, if you actually will stick that colored card in front of your number, I will be documenting table numbers, and I will give it to the facilitator. He will then proceed to say, table 1, I have a question, I have a mic. We are currently recording everything, as well as it's being simultaneously translated, so we need to make sure that everyone is mic'd so that we can hear the question. And you obviously, there's some directions on there as well, so if you'll just be patient with us. We're going to currently take one question per table for right now, and then we'll proceed back if we have a few more questions. And I'm sure that our panelists will be more than welcome to take any of your questions after their session has ended. So if there's no other questions, hopefully we'll proceed with that. Thank you.
I'd like to ask Dr. Rodolfo Irby to come up as our facilitator, and he'll be introducing our panelists and guiding that as part of the agenda with this particular group of panelists. Dr. Irby is a longtime friend. We've known each other for about good over probably 30 years. He's the CEO and medical director for the South Texas Network, a consortium of 4 to 5 community health centers with multiple clinics across multiple counties. So he has extensive experience in this whole issue of access to care. And we want to thank him for being our facilitator this morning. Dr. Irby.
Thank you. How about a hand for LaFe staff? This is a small staff, and they've done really tremendous work to get us together. How about a hand for LaFe? Okay, we have a very distinguished panel this morning. It's going to address the topic of Medicaid expansion and the impacts of that program on women's health in Texas. First, we have Eva de Luna Castro. She has been a budget analyst since 1998 with the Center for Public Policy Priorities. Very important organization in our state, involved with research and advocacy on behalf of poor and moderate income Texans. Prior to her present position with CPPP, Eva was a writer and analyst with the State Comptroller's Office, working in the areas of demographics and workforce development, as well as other policy issues. Our next panelist is Ann Dunkelberg, who currently is Associate Director for the Center for Public Policy Priorities as well. She focuses on policy and budget issues related to healthcare access, has been very, very involved with immigrant healthcare issues as it relates to the ACA and other matters, has worked with the State Medicaid Office, Health Human Services Commission, and currently serves as co-chair of the statewide Texas CHIP Coalition. Ms. Dunkelberg has received numerous honors and awards. We're fortunate to have her with us this morning. And Yvonne Gutierrez is currently the Vice President for Public Affairs and Government Relations for the Planned Parenthood Gulf Coast area. Prior to that, she served with the Planned Parenthood of San Antonio in South Central Texas and oversaw grassroots organizing and coalition building for Planned Parenthood. Her primary role has been to develop and implement legislative and regulatory plans and agendas that promote women's health with Planned Parenthood of the Gulf Coast, which includes both Texas and Louisiana. She has also received multiple awards and recognitions. We're fortunate to have her this morning. Let's welcome our panelists and proceed.
I think the clicker is up here. Can everyone hear me? Okay.
Bring it down a little.
A little more. I'm short. Ann will be down here as well. Good morning, everyone. I'm here really just to set the stage, the big budget picture, the main, the one thing that the legislature has to do before they leave Austin. We hope they'll do several other things as well that expand educational opportunities and health care coverage for Texans. But the one thing the legislature has to do every 2 years is write the state budget. So this gives you an overview of where it is that your dollars are going right now through the state budget and where the money is coming from, and then just kind of, again, just the big picture for why is there much more hope this time that the legislature could make better choices. We've had 2 sessions in a row now where programs either weren't fully funded or were just slashed. We heard from the previous panelist how education and healthcare have taken some pretty big cuts just when our communities need these things the most to ensure future prosperity. So why might things be better this time? And what you'll find out is that this time it's not going to be so much that there's not enough money, but maybe just not enough willingness to spend it. So that's an important distinction. Those of you who will be trying to talk to your legislators, you just need to push back against this idea that there is no money. There will be more than there usually is. There's never enough, obviously, but things will be better this time, and you'll see just kind of the big picture. And it'll set the stage for what the next 2 panelists will tell us. So here's just a general look at the state budget, the one that we are in the middle of right now. Texas has a biennial legislative session. They meet every 2 years, and they write a biennial budget. So they write a budget for 2 years. And what you see here is two different ways of looking at the budget. On the left side, you see the all funds budget, so all the money that the state appropriates. It doesn't capture money you're spending locally on schools or healthcare, but this is what's coming through the state budget for these areas. And then on the other side, the right side, the much smaller side, you see just the general revenue. So pretty much the state's own money that legislators can move around more or less. On the other side, there's money that really can't be moved because it's earmarked for certain things, like federal funds for Health and Human Services, or state highway dollars that when you pay gasoline taxes, that goes to our highways. So just to walk you real quickly through here, at the bottom, of course, we have just what the state helps local schools with their funding. We have more than 1,000 school districts and charter schools in Texas. This is the money that's helping pay for children's education. So whether it's with the all funds or the general revenue budget that we're looking at, you see how important schools are in the budget and how really that's where most of our dollars are going. Right above that, we have Health and Human Services. And there I've shaded it so that it's almost, I'm sorry, I skipped over higher education. Obviously, that's very important. Just to give you some numbers, the all funds budget is about 29% public school funding. And then right above that, 13% of funding is for higher education. So already, just with that basic function, helping schools and helping our universities, such as the facility we're in, we're already up to 42% of the budget. Adding in Medicaid, right above that, that's 22% of the all funds budget. Other health and human services is another 10%. Other health and human services includes funding for state hospitals and state schools that don't get Medicaid dollars, foster care, eligibility workers that help figure out who's eligible for Medicaid and CHIP and TANF and food stamps, all the safety net programs. And that's pretty much it. We just don't do a whole lot other than some just key areas, protecting children with health coverage, protecting elderly people in the protective systems that we have, and then just providing just basic access to health care. So the reason for adding those up on both sides here, I've just stopped there just with those basic things, health care and education. That's what the budget really boils down to. Almost 75% of the total money currently being spent, almost 85% of the general revenue budget. It's just going to those two things. So when we hear, like we did the last time the legislature got to Austin, that there's an almost 30% shortfall in our revenue. It wasn't ever the case that we were spending too much on any of these. There was just no more revenue because of the recession. And when you have 30% less revenue than you need, you can see why you have to start cutting some really important areas. Not because they want to, but because there's just so much of the budget that goes to these core areas that they couldn't be spared some of the hits. Now, one thing they could have done was use the rainy day fund. They left that unspent. So one issue, again, that we'll hear a lot more about this session is there could be more money if they're willing to raise taxes or just use money that's already there in the rainy day fund. For various reasons, that did not happen last time, but this time the situation will be a little better. The main point of this is that we have so much invested in just these key areas that you can't solve our budget problems or get better outcomes by just rearranging what's there. We're doing the bare minimum. We're sending most of the dollars to education and healthcare. So we're not ever gonna really tackle the long-term challenges we heard about by just moving money from one place to the other. The other funding that's way up at the top, everybody wants to know, well, that looks like a lot of money up there that you haven't even talked about. We know what public safety and prisons, we know what that is, business and economic development. Above that is the highways, mostly highway money. But what about that other? Well, that's our courts, our environmental protection, agencies that regulate doctors and dentists. So there's still a lot of important things. Again, it's not, we don't spend too much on anything that we can just say, well, just rearrange your priorities. The priorities are in the right place. It's just not a matter of enough money. It's a matter of not enough money coming in. One other thing, I get questions about this because people want to know, does this look really dramatically different from the 2010-2011 budget? It actually, the priorities, where the money is going, looks exactly the same, more or less. What's different is the total amount of money being spent. It's less than last time. It's below what we did in 2010, 2011. It's way below current services. And the fact that 2 years has gone by without paying for any growth, growth in the number of students, growth in the number of people getting assistance or getting health care, or the cost of all of that going up. None of that has been covered by the budget, which is why everybody is facing waiting lists or just not getting what they used to get. Here we look a little closer. I won't spend too much time on this again to leave plenty of time for the next two panelists. Healthcare in the state budget. It's not just Medicaid. It's other areas such as covering state employees, providing minimal level of health care for inmates in our state prison systems, funding teaching hospitals, again, like the ones that are around the state, helping school districts with teacher health benefits, helping retirees. So there's other health care in the budget. All of those together add up to what you see on that right side. About 30% of the budget at this point is health care. And driving in from Austin this morning, me and Ann were listening to NPR, and there was a story about how they're trying to change the way that inflation is calculated so that it better reflects what people actually do with their dollars. Later in the story, they did mention that one issue is it would ultimately reduce Social Security increases, which is a problem because people are trying to buy health care when they're on Social Security, Medicare premiums, out-of-pocket expenses. So the commentator really recognized when you start affecting how fast things can grow in your budget and you try and use something like inflation, you're going to hear a lot about how maybe inflation should be a good way to let the Texas budget grow. We have to recognize health care is what we're trying to pay for. 30% of the budget goes to health care. So it's not enough to cover 1 or 2% consumer inflation. In some cases, it's more like 5 to 10% increases, depending on whether you're talking about hospitals or prescription drugs, or what is it that you're trying to buy, long-term care versus a child's annual exam. There's very different cost pressures on this. So recognizing that the state is not like us in very many ways. One is that it is trying to buy health care. If we had to buy this amount of health care, we would need a lot more money every year. The state, when it doesn't have that, resorts to cuts. In this part of the budget, it cut pretty much all of these things that I mentioned: correctional health care, state employee health care, cut Medicaid last time. It also cut the big part of the pie over here. This ends up breaking out into 1/3, 1/3, 1/3 roughly if you round off. School funding is 29% of the budget. And then everything else, in higher ed, I'm sorry, everything else that we do is, no, I'm sorry, higher ed is in the rest of the budget. So it really is, this is why you hear people talking about the choices that we may be forced to make, the false choices, I think. I don't know, but some of you may have heard the controllers going around the state saying that healthcare and schools are eating the budget. And this is just not a helpful way to talk about what's happening with the Texas budget, because it's like you saying, well, I would really be so much better off, or I'd have so much more money at the end of the month if I didn't have to pay for food and housing. It's like those are the things you have to do as a responsible person. The state has to find a way to pay for these, and it's done it more or less up to now, but just saying that these are not things that both can be invested in is again, it's a false choice. Where the money comes from is something also that I'll touch briefly on here, just so you understand why does the recession hurt state revenue so much. So that last time, almost 30% hole in our revenue is what legislators were told they were facing. So here's all the money. We had previous slide, a couple slides ago, had $173 billion in total money being appropriated. This one has $167 billion in money coming in. You might see a problem there already. It's like, wait a minute, we're appropriating more than we have. That's because legislators have also kind of piled up a huge amount of balances in earmarked accounts, money that's supposed to fund trauma care, for example. So at this point, the budget doesn't truly balance, and it's also missing at least $11 billion that needs to be added for Medicaid. So that'll change this revenue chart. It also changes the spending chart that we saw. But the main thing that we should get out of this is most of the money, half of the money, comes from what you see on the left side, taxes. So when the state has a tax system that relies a lot on consumption, when a recession comes along that hurts people's ability to have a good paying job, they work fewer hours or they don't work at all, they lost their job, they also don't get paid. So they can't go out and buy things that they used to buy, like cars or furniture or cleaning supplies. They can still buy food, hopefully, most of the time, but we don't tax food, so that doesn't really affect state revenues as much. It's just plain consumer spending. Consumer spending is about 60 to 70% of the economy. And so as long as people have money to spend, we'll see it in our sales tax collections. That's the really big area at the bottom. It's also the first sign of when something's seriously wrong with state revenue collection. So 27% of money that Texas gets is from the sales tax. Some of you may also be aware that means that it really affects low-income families much harder than it affects higher-income families because they're spending pretty much everything they have on necessities, and then they have to pay these taxes. Just above that is the franchise tax, where we tax businesses. We changed the way that tax works in an effort to get more money for schools in 2006, and then totally work. So there's a problem there with that tax that people think even the way it's being imposed is too hard for some business owners or not really fair. So there's attempts to change this little piece of it, the 5% that comes from the franchise tax, but it wouldn't be changing it in a way that puts more money on the table. It might actually put less money. Right above that, I mentioned when people buy cars, the state has a separate tax, the motor vehicle sales tax. You're probably aware of that if you ever bought a car. The motor fuels tax, gasoline taxes go to pay for healthcare, highways and schools. So there's efforts to maybe revisit that. It hasn't been raised in a long time. Neither have fees on when you register your car, but just ways to get more money to pay for transportation. Would affect that. It wouldn't really generate more money for health care, but it does create a little more, it eases the pressure on the rest of the budget. And then other taxes, half of that roughly is oil and gas taxes. The more recent presentations I've done, I get a lot of questions on, what about all this fracking that's going on, like in Cuero? If any of you from that part of Texas, you think surely that's helping the state, all that oil and gas revenue pouring in. Well, oil and gas taxes are 4%, so they're in that other taxes category. They're about half of that. But they could be helping us much more. Unfortunately, we don't tax a lot of that fracking activity. There's this loophole created years ago where if you're doing that type of exploration, you don't have to pay taxes on it. So again, changes to our system so that it reflects what's happening now and where we need to be in the future would really help. But at least for now, there's no way that little tiny piece of it could be what's responsible for the sudden increase. Really, it's just that sales taxes have come back to somewhat normal. Meanwhile, spending has stayed at the reduced levels where we had cuts to schools and healthcare. So the next slide here reflects that revenue has basically recovered while spending has not. This is what the controller forecast last year would happen. That little red dotted line that you see taking a dive means that 2 years ago, the controller told the legislature they were going to have a lot less money, and that's what's reflected here. She said, all the money that we have in Texas, the state is going to collect less and less of that in taxes. So that's that dotted red line. That's what she foresaw as the future. The reality is that things got back a little better, not quite where we used to be, but that difference between the dotted line and the green line means we're going to end this 2 years with about $8 billion more in general revenue than we used to have. So that's one important takeaway. Things have already gotten better. They were not as bad as we thought they were going to be last time. And then here's maybe the most important slide. Here is where we get into discussions of money that is likely to be on hand versus the needs that will be there. And I'll steal one extra minute, but just go through this really quickly. What we have in that first bar is the money that legislators thought they had when they wrote this budget. So that's not really enough to cover where we used to be, $79 billion. And they left some money in the rainy day fund unused. But where we're probably going to end up with that extra $8 billion in general revenue coming in is about $86 billion. The good news is that's enough to cover what the 2012-2013 budget will end up being once we pay the Medicaid IOU. where we need to be in 2014 and 2015 is about 95 billion. That's just that's just assuming 10% growth. That 95 billion and the 96 billion that you see next to it, it's very likely that in the next 2 years we'll have just as much money coming in as we would be able to, but that we would need to fund services just growing from here on out. And then the final thing is really where we need to be to go back and undo the damage done to schools and to our healthcare systems. So here, the really good news, if you're an optimist, which we all kind of need to be, is that if you were willing to use all the money that might come in a 10% revenue estimate growth scenario, plus the rainy day fund, which is going to grow up to about 13 billion, you actually have enough to do all of this. So again, the first thing I said was there is very likely going to be enough money. So it's a matter of saying, look, how these dollars are allocated is up to the legislature, but it's up to us to make sure that they understand we know what's at stake here, and we won't accept the excuse that it's just not possible. Because even if the revenue estimate doesn't turn out to be as good as 10%, there are other options that we have. We do that in Austin. We present other scenarios, other ways to raise revenue. But the main thing is that in January, if we get at least a 10% revenue increase, we could be able to do the expansion to adults of Medicaid. We could be able to undo the damage done to our schools. So this time, the main message is don't just let somebody tell you, sorry, this is the third time in a row that it's not possible, because it's within reach is the main thing that you should understand. Thank you.
Microphone now. Well, I was very, it made me a little nervous when the translation services guy said that they might tell me to slow down at some point, because as usual, I've tried to cram a lot of information into 15 minutes, so I'm going to try to stick to my allotted time. And so basically, my job is to focus a little bit on, I think probably everybody here is aware that one of the things that is part of the Affordable Care Act, Obamacare, is a Medicaid expansion. We're going to talk a little bit about that, and because of the way the Supreme Court ruled on Obamacare last summer, unfortunately, whether or not to do the Medicaid piece has become a state option, and since our governor is very reluctant to do anything in the area of health care, he's expressed some opposition to that. So we're going to talk, I will get right on that, Mike. How's that? So we're going to talk about the impact on Texas, what it could mean for Texas, and hopefully be able to give you some flavor of what that could really mean to families. So first, I'd just like to show, this is our uninsured for Texas in 2011. So most of our uninsured is that big pink slice, and that's working age adults from 19 to 64. So that's where our big challenge is in Texas, is trying to get our working age adults insured. They're almost twice as likely to be uninsured as kids are in Texas, and that is completely because our kids have access to Medicaid and CHIP, but there's no similar kinds of public coverage for adults. So we have a much bigger gap for adults going forward. And one of the groups I talked to recently asked me to add the information about Massachusetts because, of course, that's a state that has Romney Care, which Obamacare was loosely based on. And in Massachusetts, only 3.4% of their population is uninsured, compared to 23.8% of the Texas population of all ages. So this kind of system, while it's not going to cover everybody, can sure make a big difference. This is another way of looking at our uninsured in Texas, just showing you how different the insurance picture looks depending on what age group you fall into. And I think one of the main things I would point out is that we do have a really big role for Medicaid in covering our kids, as you can see over there on the left. Yes, it does work. And then our adults are much more likely, of course, to have employer-sponsored coverage because your adults have jobs, and that's who gets employer-sponsored coverage in Texas is usually just the worker. Much less likely in Texas for spouses or dependents to have their coverage contributed to, unless you're lucky enough to work for the state of Texas or one of the really, really big employers or the universities. Always important to touch base on the whole question. Sometimes people want to dismiss the whole uninsured issue in Texas and say it's all because of our immigrant population. Well, that in fact is not correct. If you go into the census data and you take out all of the non-US citizens, both people with lawful status and people without documents, it turns out that we still historically, until this year, always still had the worst uninsured rate in the entire country, comparing us to all the other states with the immigrants still in their numbers. This is the first year that we weren't still dead last. Now we're actually tied with California, Florida, Louisiana, New Mexico. But still, that's with all those states' immigrants left in their numbers. And half the immigrants in the United States live in California, not in Texas. So it's important to understand that while immigrants in Texas, lawful and undocumented, do have very high rates of being uninsured, that even if we had no immigrants tomorrow at all, we would still have a very serious uninsured problem. And the low rates of employer-sponsored coverage in Texas are the biggest factor in that, with some of the low coverage of adults in Medicaid that we're going to talk about in a second being sort of the number 2 factor. This is a chart that makes sense to somebody like me who's always thinking about people's incomes in terms of the federal poverty income level, because that takes not just the dollars you make, but adjusts it over how many people that income is trying to support. And this is our same 6.1 million uninsured Texans in 2011, but showing you which poverty income slice they fall into. And really the main reason I like to show this is, plug in a power source if you have one. Anyway, that pink slice up there at 11 o'clock is about 656,000 out of 6.1 million, and that's the only part of the Texas uninsured population in 2011 that had an income at 4 times the poverty level or more. And that's important because under the Affordable Care Act, under health reform, people up to 4 times the poverty level would be able to get some kind of sliding scale help with their health insurance premiums. And so, as it says at the very top, 89% of our uninsured fall into an income group where if Texas does everything they can on the Affordable Care Act, the vast majority will have some help either through Medicaid or through private insurance sliding scales with accessing health care. Now, the big exception to that is over here in this italicized portion. And of course, as we mentioned before, our uninsured population does include non-US citizens. We think about 2/3 of those are undocumented and about 1/3 are people who have lawful permanent residence in the United States. And the undocumented share, about 1.1 million out of our 6.1 million uninsured, don't have any new resources, at least not full coverage resources, provided for them under Obamacare, under the Affordable Care Act. So Texas does have that special issue, and I would say that those people are at all different income levels spread throughout this pie, but that will be an ongoing consideration for Texas going forward. We've already seen some other estimates like this, but it is important to understand that our Hispanic population, Texas does have the highest uninsured rate, and you have some much more detailed materials from LaFay in your packet by age group and that break out sources of insurance that I think are very helpful and easy to understand, which is always a plus. This is a picture of our Medicaid program as of August. A lot of the groups that I talked to are stunned to realize that our Medicaid program is 2/3 children in Texas. In August, there were 2.5 million children in Texas Medicaid. There were another 580,000 kids covered by CHIP. Then the 2 largest groups of adults in Texas Medicaid are seriously and permanently disabled adults, most of whom get supplemental security income benefits, and then very low income seniors, mostly below the poverty line, a few of them just above the poverty line, but needing, I guess that really did need some power. We're calling IT. Okay. Where were we? Yeah. Oh, you do great. And I can go get it on my iPad too. But this happens to me a lot. I won't go anywhere without a power cord because of this. Batteries are unreliable. I'm glad she's going to bring me a hard copy. Then I can jump back in there. So we were looking at the income range, and then the next thing probably in the slides that you're not seeing is a picture of kind of the framework for coverage under the Affordable Care Act. You're fine here. There we go. Awesome. Okay. So why are so few? What we didn't get to see before the slide disappeared. There were some tiny little slices in the pie that were the only kind of working age adults who aren't seniors or people with disabilities on Texas Medicaid today. There were about 80,000 some odd adults who are actually getting cash assistance or recently got it. So that's how few. We have 25 million Texans. There were only in August about 85,000 adults who were actually getting cash assistance anymore. So we definitely ended welfare as we knew it in Texas. And then there were about another 120,000 or so, I'm getting that number wrong, it's right in front of me, 145,000 adults who were just as poor as those cash assistant adults, but they weren't getting cash assistance. They were just getting the Medicaid coverage that went along with it. And so you see this glaring difference. In total, you have about 225,000 parents, 2.5 million children. So how did we end up there? Well, the main answer is your Texas legislature. They adopted the income limit for parents in Texas Medicaid as a dollar amount, a fixed dollar amount in 1985 without any annual update for inflation, and has never been updated since 1985. So it's literally the same amount it was in 1985. And as shocking as that is, believe it or not, there's at least a dozen other states that look almost exactly like us with regard to how incredibly low their income caps are for parents to get Medicaid. So the vast majority of our kids on Medicaid in Texas have parents who do not qualify for Medicaid themselves, and in a very high percentage of cases they're uninsured as well. The next slide that you're not going to see is, no, I'm sorry, we're almost there. Yay. That was very fast. I don't think there was a lot more we wanted to talk about here, but I will remind you that this was our slide here. Maternity coverage, about 55% of the babies in Texas are delivered by Medicaid. As stunning as that is, if you're not familiar to this, in almost all of the states, it's somewhere near half. In some of the richer states, it may be down around 45%, and in a state like Texas with higher poverty, 55% of our babies are being delivered by Medicaid. But that coverage ends 2 months after the baby is born. You don't get it until you're pregnant, and it goes away 2 months after the baby's born, so it's temporary coverage. And I think everybody's probably aware that Medicaid does not cover undocumented residents at any age. Another thing that you may not be aware of is that the good news is that Texas does provide Medicaid and CHIP to legal immigrant kids, so up to age 19, but at 19 and older, we are excluding those adults who have green cards and other kinds of permanent residents from Medicaid, and that is another choice of your state legislature, and Texas is one of only 4 or 5 states that has done that. This is just a quick way to look at, to visualize again the difference between how we cover kids in Medicaid versus our parents. And so this little bitty income limit that they set in 1985 was, so if I was a mom with 2 kids, and let's say I've just escaped a violent household and moved into a domestic violence shelter. So I don't have a job yet, and my parents are giving me a little bit of money to help me get by. Whatever money, so I'm not working, I can't have money from any source that's over $188 a month. That's my income limit. If I go over that, I lose my Medicaid. Now, if I get out of the shelter and into some kind of supported housing situation and I go to work, I can't make, I can have $120 a month in earned income that they will ignore and let me stay on the program. Still, I can't make more than $308 a month for me and my 2 children and keep my Medicaid, even though my kids can stay on at a much higher level. So basically, that's the big takeaway. You have no category here at all for an able-bodied adult who doesn't have dependent children, and that's part of the federal Medicaid structure. And then in Texas, we've chosen to keep coverage for parents very low as well. So this is sort of setting you up for why the change that is now an option for Texas under the Affordable Care Act is potentially such a big deal in Texas. We've kept it so low that the potential to take it up makes a bigger difference here than it does in some states. Now, I'm not going to walk through the whole coverage structure. You're probably aware that some good things from Obamacare have already happened, being able to keep kids on your policy to age 26, children can't be turned down for pre-existing conditions anymore. A lot of people got refunds on their insurance last summer, but most of the big coverage gains aren't set to start until 2014. And the way that structure was supposed to work, a building block of it, the first building block was that most people would still get their coverage from employer-sponsored coverage. If that was where you were getting it and it was decent coverage and it wasn't unreasonably priced, you're supposed to stay there. But then on top of that, there's supposed to be a Medicaid expansion for every U.S. citizen up to 133% of poverty, and then on top of that, a new health insurance exchange where the people who aren't getting affordable good coverage through their jobs can go get coverage. What the Supreme Court did to us was essentially pluck out that Medicaid piece, potentially. So you have states that choose not to do the Medicaid expansion could essentially go into 2014 with a bunch of new programs starting up for people above the poverty line, but nothing for people below the poverty line. This is what the Congressional Budget Office, this is their comparison of health care in the United States if we hadn't done reform with what it's going to look like now. And you see the main difference is you've got this Medicaid chip slice, this dark blue slice that gets bigger, and then you have a brand new slice that's kind of light blue right next to the Medicaid slice, and that's your new health insurance exchange where you would get private coverage but with public subsidies. And as you can see, there's still an uninsured population under either scenario, but under health reform, the uninsured population is quite a bit smaller. So what do we think will happen in terms of numbers if under the ACA? So we have Texas experts like Dr. Steve Murdoch, our former state demographer and former head of the U.S. Census, who's worked with his colleague, Dr. Michael Klein. They've done sort of a low, medium, and high expert guesses about how many people will gain coverage. And their guess is that even at just the medium kind of enrollment scenario, our uninsured rate in Texas will be cut in half. So about 3 million people would gain coverage. So that's your good news. The bad news is that half of that gain only comes if we do Medicaid. So basically what they're saying is half of the insurance gains for Texas if under the ACA will only come if we do the Medicaid expansion piece. There's a whole range of estimates of how many people out there are potentially eligible, and then there's always another question of how many of the people who could sign up will sign up. Those are never the same number. But basically, even our Health and Human Services Commission is estimating that about 1.3 million U.S. citizen adults could potentially sign up for the new Medicaid option if Texas does it. And when I go into the census data and look at that, it looks like, and this is just U.S. citizens. Remember, this particular piece of the ACA is only for U.S. citizens. So even just going into the numbers for U.S. citizens, over half of this group is of Hispanic origin. The Health and Human Services Commission that runs Medicaid and CHIP, they project that about 1.1 million of those potentially eligible U.S. citizen adults who are uninsured are going to sign up by 2016. So about 85% of the folks who are eligible. And they are also estimating that about 400,000 children who are uninsured today, who are eligible for Medicaid or CHIP right this very minute, but haven't signed up for a whole variety of reasons, they think that kind of take-up rate, that sign-up rate is going to go way up, and they've built that into their budget calculations. But if Texas opts out of the Medicaid expansion, then we have, as I said, this new health insurance exchange with sliding scale help with premiums, but under the law, that sliding scale help is only available to people above the poverty line, because Congress, when they wrote that law, never ever dreamed that the Medicaid piece would come out as an option. And so you basically, as I've said before, would not have any solution for your folks under the poverty line. And of course, what that means for communities is, you know, who pays for those? Local taxpayers and charities are the ones who take care of the uninsured in Texas. You use lots and lots and lots of local tax dollars, and you're not drawing down any of the federal match that could be available under this Medicaid expansion, which would be $9 federal dollars for every $1 that the state puts up, or better. So this is just a picture of how the coverage could look in 2014. And again, really, I just wanted to show you that here's the problem. We've got kind of a system we're thinking of here of sliding scale help as you go up the income scale. But our question is whether we're going to be stuck with a hole right here at the bottom for adults where Medicaid is and nothing for those people. I'm sort of beating this horse to death here, but this is sort of the difference in the uninsured rates we would look at. If we do the Medicaid expansion, our uninsured rate would drop down to about 12%. If we don't do it, we'll still be stuck with about a 17% uninsured rate. So just to get those dollars straight, the federal government will pay for the first 3 years of the Medicaid expansion if we started in 2014. So 14, 15, and 16, those adults wouldn't cost Texas a penny, but starting in 17, we would pick up a share of 5%. And then it would top out at a 10% share in 2020, and the feds would always pay at least 90% of the cost for these new adults. Now the kids are kids that we're supposed to be covering right now. So Congress didn't give us any kind of award for doing a bad job of signing up our kids in Medicaid, and we have to pay the regular Medicaid and CHIP match for those kids. And that's closer to 39 cents on the dollar for Medicaid. So states are thinking about those costs as well, although most of the experts, and indeed even the state agency, seem to think that they're going to have to pay for those kids no matter what, that just all the publicity around the country about the Affordable Care Act, that even if Texas doesn't do the Medicaid, that those kids are still going to show up in higher numbers because there will be so much more publicity about the fact that they're eligible. So the official cost estimates, the Health and Human Services Commission, our agency that does Medicaid and CHIP, has said that for the next 4 years, and as you know from the budget presentations and your experience, Texas legislature meets every other year. We write a 2-year budget. So when they did these estimates at the agency, they did them for 4 years. That's basically 2 budget periods. And so they've said over the first 4 years, Texas would have to come up with $3.1 billion of its own dollars and would draw down $27.2 billion in federal matching funds over that time period. That's enough to support 33,000 more family doctors in Texas or nearly 90,000 more registered nurses. It would certainly, now that's certainly not how all that money would get spent, not all of it, but it does give you a sense of how powerful it is to bring that kind of money into our state economy. Most of they have given us the details. That's about $1.3 billion is needed to cover the new adults, and actually more of the money is needed for those kids. Even though kids are cheap, even though there's fewer kids, the fact that we have to pay 39 cents on the dollar for the kids and we're paying next to nothing for the adults means that ends up being a little bit bigger budget cost for us. I'm gonna point you to, back in the corner, there are a lot of resources. I want you to make sure when you do have a break that you get over there. There's links to how you can get this county level data, both on the uninsured and on how much money every county in Texas would get under the Medicaid expansion. And so just to hit the high points, Harris County is the biggest county with the biggest impact. They would get, according to the Health and Human Service Commission's estimates, they would get almost $1 billion more every single year over the next 4 years if we did this Medicaid expansion to pay health care costs. And I've got Bexar County, I believe, on the next slide. Bexar County over $500 million a year. And so it's obviously huge in the big urban counties, but even in the small rural counties, the numbers are pretty amazing, and they could really, really make a difference in local economies. Dr. Ray Perryman has also done an analysis. The title of his analysis is Only One Rational Choice for Texas to do the Medicaid expansion. And he estimates that the state is actually, in the near term, gonna make $1.29 in state revenues for every dollar it spends on this Medicaid expansion. You would think that this would be enough to put everybody over the top, but we live in such a politicized world that we are just beginning a conversation about really getting to yes on this Medicaid expansion. And one of the things that he said down here, I put in blue because I think it really speaks to the question of the impact on families. One of the things he pointed out is that increased income for uninsured Texans who gain coverage is really going to make a difference, as it's one of the benefits. It's like if you're not having to struggle to put huge percentages of your income into health care, then you're potentially able to do other things. Feed your family, buy a home, save for college, save for retirement, all kinds of things that people can't afford to do now. So I urge you, again, to check out some of these resources over here, and we can help you connect with all this data. So these are some of the high points that I just kind of want folks to remember. We could potentially be covering 1.5 million additional Texans with this Medicaid expansion. that over 4 years we might have to come up with $3 billion in our state budget, but we would draw down over $27 billion in federal funds. That you may be aware, you may have heard about this big Medicaid 1115 waivers that all the big counties have been working really hard on. Well, the counties all over Texas are struggling to find $12 billion over 5 years to draw $17 billion in federal matching funds. For this program, for this expansion, we only have to find $3 billion, and we'll draw down $27 billion over just 4 years, and that money keeps coming, whereas that waiver is over at the end of 5 years. So my point is not that the waiver isn't wonderful, because it could potentially make our health systems much stronger if everybody does a good job on it, but that these are very good partners to each other. And certainly if we can find the resources to do that waiver, we should be able to find the money to fund this Medicaid expansion. I just want to point out to you that I can help any of you who are interested in tracking down these resources either on our website, or Dr. Perryman has his report on his website. And as Juan pointed out, we have a lot of coalitions working on supporting better access to health care for all Texans and kids, and protecting our Medicaid safety net, as well as trying to move forward with the Affordable Care Act. And I think that's it. Thank you.
Okay, just because I'm wearing heels. No offense, guys. Okay, so I don't know where Amy is. I'm assuming I might need to click on this. Here it is. Okay, well, thank you all so much. I'm glad to be here today speaking about something that has become unfortunately controversial in our state, which is access to women's health care, specifically for low-income women and Latinas. And I'm going to talk to you a little bit about Planned Parenthood's role in that and what has been going on at the state level regarding access to care. So just briefly, who Planned Parenthood is. Here in Texas, we have 6 different affiliates providing care throughout the state. Nationwide, we have nearly 800 health centers providing medical services, sex education for women, men, teens. So 1 in 5 women in the entire country has been to a Planned Parenthood clinic in her lifetime, which we think is pretty fascinating. Our goal is to increase access to reproductive care and sex education. And then also, Planned Parenthood is truly the nation's leading provider of sexual and reproductive health care. And we work with allies and partner with healthcare providers really across the globe to fulfill our mission. And here in Texas, we provide care to nearly 260,000 Texans a year. So who is our typical client? You know, I think that there is a lot of misconceptions about Planned Parenthood and who we serve. Our typical patient is between the ages of 20 and 35 years old. 2/3 of our patient population are women of color. About 40% of those women are Latina. These women are employed but not insured. And Planned Parenthood is often these women's only source of health care. And we do provide services to men too. We're not biased. So a little bit more about our health care. So 95% of what we do is gynecological health care. So your well woman exam, your Pap test, your breast exam, STI testing and screening, prescriptions on site for birth control and antibiotics, medical and social service referrals, and sexual health education for young people as part of our service delivery as well. So a little bit about women's health in Texas. So I think that Anne and Eva did a beautiful job of really explaining where we are as a state. I could just listen to them all day, even though it's tragic. So 30% of women in Texas are uninsured, which is really the highest in the state. And here in Texas, we are one of the top 10 states for cervical cancer rates, which, as you all know, and any medical doctors in the room, you know, with the invention of the Pap test, cervical cancer really should not exist. And we do see among Latinas that Latinas really contract cervical cancer at a much higher rate than non-Hispanic white women. 56% of our births, I believe Ann said 55, about 55, 56% of our births are paid for by Medicaid in Texas. And that it was approximately $2.7 billion in state fiscal year 2009, according to the Department of State Health Services. And to kind of put this into perspective of why family planning is so important, and really it is a cost savings, $1 spent on family planning saves $4 in prenatal care, delivery, and first year of infant care for Medicaid. So let's talk a little bit about Latinas and specific access to health care. So we look at who the provider of health care is for women in our country. And between the years of 2000 and 2008, the number of women in need of family planning services really increased among the Latina population of about 27%, while in the African American population increased about 11.5, and actually in white women it decreased by 1%. So about 3/4 of poor women, women who are uninsured, African American and Latina women, and those born outside of the United States, they obtain their health care at family planning centers, at community health centers. This is often their only source of health care. So as we mentioned earlier, and I think that Ann talked about this as well, 16% of the population nationwide is Latino, and about nearly 40% of Texans are Latino. So it kind of puts it a little bit into perspective of who the women are who are in need of these services and where they're obtaining their health services. And then in Texas, 46% of Latinas are uninsured, compared to 17.5% of non-Latina white women. So to talk a little bit about what happened with family planning in Texas, and I know that this has been a huge topic, and especially since the last legislative session. So what we saw occur was that our legislature cut the budget for family planning by over 2/3. And this was not a budget cut in the sense that we couldn't afford it, the money needed to go away. This was really the reallocation of dollars to other programs, not necessarily programs who were requesting the money or for any specific purpose other than political. And I think that's fair to say. The dollars were shifted, and this is the family planning program. So this is basically Title 10 and 20, which is a block grant program. So there is a ton of flexibility. This is not like Medicaid, for who is eligible for these funds. So really, you look at the women who can access these funds, mainly undocumented women, teens who do not qualify to receive family planning services through CHIP. So this is a large portion of this population that would then lose access, right, because they don't qualify for Medicaid. And then another thing that we saw happen while this occurred in the 66% reduction is that the legislature decided to tier the funds for providers. So basically, based on the kind of provider that you are, you could access the dollars. So tier number 1 was, the public hospitals. Tier number 2, federally qualified health centers, which, again, wonderful entities. Nobody is saying that they're not fantastic. And then in tier 3 were specialty clinics, including family planning providers. So what that did was cutting the funds by 66% and then tiering those funds among the providers who could actually receive those funds. So based on this cut, the Legislative Budget Board stated that in the years 2014-2015, what we were going to see, the repercussions from this 66% decrease was almost 300,000 fewer women would receive care, 24,000 additional births to Medicaid-eligible women, and a $273 million additional cost to taxpayers. Now, this is based on a $61 million cut that we would see in family planning. So, doesn't really add up now, does it? So in regard to Planned Parenthood, and as I mentioned, the tiered providers, so tier 1, tier 2, tier 3, Planned Parenthood fell into tier 3 of the providers eligible to receive these funds. So what happened in this cut with Planned Parenthood is that we lost about $12 million in that block grant funding to help the poorest of the poor, those in the most need, undocumented and teens, among those as well. closure of 12 Planned Parenthood clinics across the state. Now, more than 53 family planning centers closed statewide because of those cuts. So even though, you know, this cut, being political, was targeted at Planned Parenthood, the repercussions really were felt statewide by family planning centers across the state. Most of those in rural communities where they were the only source of family planning and women's health care. So, you know, again, concern about how are we going to continue to help these women in these communities where there is not another provider and where there is such a significant loss of resources. And the fact that even if there was another community provider, how are those community providers really going to be able to help the patients who lost access through their normal provider? So you think about how difficult it is for a woman, a low-income woman, who maybe already has a family and children, who doesn't maybe have access to transportation, who had a provider who is now not included in this program. They are now transferred, quote unquote, to another provider who has also lost funding. So these other providers, they get a huge significant cut in funding and a surplus of patients who are now going to be coming them, assuming that they can actually access them. So there were a lot of studies in regard to what happened in Texas because, of course, we are always the fascination of the rest of the country in what we are doing to our residents. And so Joe Potter, who is actually at the University of Texas in Austin, Dr. Joe Potter, and a collection of his colleagues produced some really great research, and it was printed in the New England Journal of Medicine recently, addressing the cuts to family planning in Texas. So what Dr. Potter and his colleagues looked at was, what are we talking about in regard to the cuts at the places that normally provided these services? So as I mentioned, the Tier 1 and Tier 2, which were the funded hospitals and the federally qualified health centers. So about 127 health centers saw no change. 28 of those closed, although, because it was such a significant decrease in funding. And then 9 of them reduced their hours. So that's significant, even to the ones who were in the top 2 categories of providers who could receive these dollars. So then you look at Tier 3, which was the traditional family planning providers and other community health centers, 25 clinics were closed, and then 29 had to reduce their hours. So also quite significant. So what is the impact? So while fees at traditional family planning providers, community health centers, public hospitals are traditionally less than what you would see at your private gynecological office, it's still significantly more than when you were used to paying nothing for your birth control, or very, very little. And so this really remains out of reach for the poorest of women. And what we did not traditionally used to see was that women would never be turned away, because especially in Planned Parenthood as a nonprofit, this is our mission. You don't turn women away when they need care. Well, for a lot of providers, they really have no other funding source, and there is no other choice. If a woman cannot pay for even the smallest amount for her Pap test, for her breast exam, for her pack of pills for that month, then there is really no way to provide this care for her. And what we would often see is that women would pay for what they absolutely needed and forego something else. So they would not, they would maybe get their birth control, but they would forego getting their STI test, even though, that's really important, as that can lead to other significant medical issues. And really looking at reducing these funding cuts, the operations went from about 74 active family planning participants to about 41. So even some of the largest family planning providers, including University Health System here in Bell County, saw their budgets really significantly cut, and a lot of them lost up to 75%. So that was quite a jump. I'm going to turn now to the Texas Women's Health Program, because that has been in the news quite a bit. We all know, which I talked about before, the family planning cuts. This was the block grants. This was the poorest of the poor. These are women who did not qualify for Medicaid and teens, right? So what I was talking about before. The Medicaid health program is really phenomenal because what it did, it was Texas taking advantage of an expansion program for family planning. I spoke about earlier the fact that $1 spent on family planning saves 4. So when you are increasing access to family planning, you're saving more money, especially when you are in a partner project with the feds and you get a 90-10 match. So that is really significant, and it's a really cost-saving effort. So back in 2005, this legislation was passed. January of 2007, the program began, which expanded eligibility from, as Ann said, basically you've got to be homeless to qualify for Medicaid in Texas as an adult with no children. But if so what this did is it expanded it all the way up to 185% of federal poverty level. So that was basically like $32,000 for a family of 4, which is a significant jump. So we, after experiencing this program for a while, and it was successful, in 2011, right out of the gates, the Legislative Budget Board came out with a report and said, not only do you guys need to renew this program, you need to expand it. You need to include men, you need to include teens, we need to make sure we're doing more outreach about this program, and it's a real cost saver. So, and in 2009, the state estimated that about 1.2 million women in Texas qualified for this program, which was significant. And if you'll see, the number of women, did increase year to year. Nowhere near the eligible women for the program, but 126,000 of January of this year. So a little bit more about the Women's Health Program. As I mentioned, it covers basically, we affectionately call it the Do Not Get Pregnant program, because it basically covers your PAP and your annual exam, and then it covers a form of birth control for the year. So you get your annual exam, you get your birth control, you get your STI testing, you don't get your treatment, and a lot of times we would be able to use that other title-funded dollars for the treatment, but for Texas, this was pretty good. So, and then those were the women who are eligible for WHP, U.S. citizens, 18 to 44, so women of reproductive age. You're not pregnant, you're not sterile or infertile, and then those are the family limits, the family income limits. So if you look by region of the participation in the program, you'll see that Southeast Texas had the highest, with the Valley, southern Texas area coming in the second highest, and kind of middle of the state coming in about 3rd place. So it was really significant in the places of need. So great success. Reduction of 8,215 expected births for 2010. HHSC estimated the decrease in Medicaid costs about $90.2 million for all funds, which is great. After paying costs associated with WHP, services saved $54.2 million, also fantastic. And then actually, what the state actually had to pay, their reduction in Medicaid costs totaled about $27.2 million in GR. So the state did see significant success, which is why the LBB was, really kind of trying to pound down the gates and make this thing continue. And if you look at the expenditures, you see the state's share of the costs, which was about $3.5 million a year. And then they were only spending about $50,000 a year in evaluation and outreach. So their total expenditures, based on what the total that they were bringing down, was really significant. And I took this out of the evaluation report from the state because the state really wanted to target Latinas with this program, which is great. I didn't think they were doing enough. Because what they stated is that they were going to produce more flyers, we're going to get more education out of the community. However, they were spending basically $25,000 a year to educate women about this program. They've got about 125,000 participating, and 1.2 are eligible. So maybe they could have done a little more. I don't know. So Planned Parenthood and the Women's Health Program. So we went gangbusters. We really took an opportunity to enroll each and every patient who walked into our health center into the women's health program. We knew this was fantastic, and we wanted to continue. So we comprised of only 2% of the providers who were in the program, but we were actually providing the most care. So 62% of all the other WHP providers had 10 or few individual patients per year. So other providers, if we were not participating in the program, would have to expand 5-fold if Planned Parenthood was not in the program, because we were such a huge component. So Amy is telling me it's time, but I'm gonna just really, really quickly go through the rest of this. I'm sorry, translators. So basically the state has done anything and everything in its power to exclude Planned Parenthood from participating in the women's program because we have a completely separate corporate entity that provides access to abortion. So in 2012, HHSC implemented a rule that excluded Planned Parenthood from the program. We then in turn sued the state in federal district court over our exclusion and received a preliminary injunction. Of course, the state turned around and appealed that to the Fifth Circuit Court of Appeals, and the Fifth Circuit agreed with the state, shocking. Governor Perry announced that he was going to have a new state program that was not going to take any federal dollars because the feds told Perry, you can't exclude a provider from Medicaid. Medicaid is a program of choice. If you have a Medicaid card, you can go where you want to go as a Medicaid recipient. So Perry said, I don't care, I'm gonna exclude Planned Parenthood. So he announced that he was gonna start his new program, which was going to cost Texas taxpayers $200 million over 5 years, and it would begin on November 1st. So leave that 90-10 match on the table. So continued attempts, so then DHS adopts a new rule that would then kick Planned Parenthood out of the state program. We filed a claim in state district court for exclusion from the federal program, which was still going on. The state decided, even though they had said they would start their new program on November 1st, that they'd go ahead and continue to take that 9-to-1 match until the end of the year. And that Planned Parenthood, even though they could legally kick us out of the program, they were gonna allow us to continue. So all of this stuff has been happening very recently. We received a preliminary injunction to continue in the program, which the Third Circuit Court then struck down. However, just this week, a patient from the Rio Grande Valley has actually stated that she is going to file suit against the court for Planned Parenthood's exclusion because that is her provider. So we are waiting, in summary, really to see what happens next. And as of January 1st, there will be a new state program. We're waiting to find out whether or not we get an injunction in order to continue participation in the program. It is not about Planned Parenthood. It is not about whether or not we can participate. Of course, as a provider, we want to be there for our patients. We know that the vast majority of these women are going to lose access to care once Planned Parenthood is no longer in the program. So we are going to do everything we can to remain in this program, even if it means filing a different lawsuit every time we have the opportunity to do so. So again, we are waiting to hear from the next court, which we should find out quite soon. Because they have to start on January 1st. So just really quickly, George Washington School actually stated that Planned Parenthood serves the majority of these patients. Alternate sites are not able to do so. More women may be exposed to gaps in birth control coverage because of problems affording or scheduling health care. And a recent analysis from the CPPP. So the Women's Health Program rule was designed to exclude has led to nearly 100 healthcare providers, including Planned Parenthood, to be excluded from no longer participating in the program. Together, these providers were 2/3 of all of the providers. So what are the repercussions? Time will tell, but what we are witnessing is the true dismantling of a safety net that has taken decades to build. Family planning was actually started by George Herbert Walker Bush in the 1960s, believe it or not. But now we are seeing that crumble in Texas, and the women who are going to see the significant really effects and hurt by this are Latina women, the women who need the greatest access to care. So thank you very much.
We have a few minutes for questions, and I believe table 7 has a question. Table 7? No? No? Your question was answered. Okay. Okay.
Okay.
Okay.
So do we have any other questions? Well, if you'll just raise your hand, we'll come to your table with the mic. To any of our panelists, anything on the budget? About Medicaid expansion? Plan? Okay, thank you.
I have a question, I guess, for the whole panel, if you will. Well, I assume after this summit is over, you're going to come up with a legislative agenda and legislative priorities to work the legislature. But I don't know if you want to answer this question publicly, but do you have someone that's going to carry the bill most? No? Oh, okay, I'm sorry. Do you have someone you're working with, I'm sure you are, that's going to be working on with one of your priority bills, particularly the benchmark on Medicaid?
So you're asking specifically about whether there's leadership moving forward for the Medicaid expansion?
Correct.
Okay. It's a really good question. And interestingly, I think the answer is that there's actually, on the first day that they allowed early filing of bills, there were already a couple of members who filed legislation. Senator Ellis from Houston, as well as Representative Burnham from Fort Worth, and I'm aware of several other members who intend to file legislation on it. But I think the important thing to understand is that what we really have to have happen is for everybody, and I mean, you know, everybody in this room who thinks that this is something that Texas needs to do, there needs to be some point at which you are talking to somebody about it, your elected officials. And some of the people that it's be most important to talk to would be not just your local state senators and state representatives, but also your city council and your county commissioners, because and business people, if you have the ability to do that as well, because really what has to happen is we have to have everyone looking at these billions and billions of dollars and millions of Texans who could gain coverage and coming together and saying, you know, politics aside, we have to do what's right for Texas. Texans aren't going to get a discount on their federal income taxes because our governor decided that he had an ideological problem with the Medicaid expansion. We're going to be continuing to pay to the federal treasury while all the other states, you know, have this big reduction in the uninsured and have savings to their local jails and savings to their health departments and savings to their public hospitals and health districts. But we're just going to let all that lay on the table for Texas. We're not going to give ourselves that benefit. So what we really need, more than we need anybody to file a bill, is just for that conversation to get as big and as diverse and as inclusive as possible. And you know, in an ideal world, I would see lots of city councils, lots of county commissioners and county judges, all of the big health districts, et cetera, all making a point of speaking out for the need for this to happen, and you know, that Texas really needs to bring this money in to build our healthcare infrastructure. So, and I think, you know, if you follow Cover Texas Now Coalition that LaFay is a membership of, and if you Google Cover Texas Now, you can get information about our coalition. There's also an organizing umbrella called Texas Well and Healthy, where if you're not part of an organization but you want to sign up as an individual, you can get on an email list to find out what's happening with health reform and with Medicaid expansion. So I hope people will really get involved in whatever way makes sense for you. Obviously, some of you, I've seen folks here from Texas Organizing Project. You've got COPS Metro here in San Antonio, and all of these organizations are all working on trying to get the Medicaid expansion. So whether you're coming at it from being a hospital administrator or a member of a church or anything in between, there's some way that you can get involved. And I really do think the most important thing that has to happen is for everybody in the legislature to be hearing such a strong, consistent message about how important this is to Texas that it sort of creates the ability for our very conservative state leaders to say, you know, the will of the people, and to back off and to let this thing happen for our state. So we will have allies, but we need all the allies we can get. Thanks.
I wanted to add to that really the chambers of commerce, getting that and to add that to their legislative agenda is huge. A lot of them have policy committees, so if you can ask them to have their policy committee add it and be approved by the overall chambers, then that is a really great opportunity because a lot of them have individual lobbyists who work in the legislature as well.
Any other questions? With that, then we're going to close this session. Thank you.
I know you guys, we're going to bring on, we'd like to have our other panelists step up, our panel 2, but I wondered if everyone could just stand up for a second. I know you're a little tired. We don't have any formal breaks. You know, there's not a lot of area out there. So stand up, take a breath, certainly step out if you need to for a second. They're going to do a little something, I think, on a speaker here for about 2-3 minutes. So talk to your friends for a second, and we'll get started in just a couple of minutes.
I think I saw you in the elevator this morning.
Yes, yes.
Trade plates or trade chairs? Which one was from?
Oh,
okay.
this is
I
trade.
didn't know who you were talking to.
Great. Thank you.
Material? I wanted everybody to know that we've gotten more material that's come to the table. If you have a minute and you want to take a little brisk 30-second walk over there, we're getting some more material, a lot of this content.
Amy.
Mic check, testing 1, 2, 3. Mic check, testing 1, 2, 3, 4. Mic check, testing 1, 2, 3. Do you need more?
Hi, how are you?
Mic check, testing 1, 2, 3, 4. Mic check.
I'm supposed to bring my own slides. Okay, great.
Hello, hello.
Oh,
Mic
okay.
check, testing 1. Excuse me? Oh, it's fine. Yes, sir. Thank you. Mic check, testing 1, 2, 3, 4. Mic check. Mic check, testing 1, 2, 3. Mic check, testing 1, 2, 3, 4. Mic check. Mic check, testing 1, 2, 3.
Yeah.
Mic check, testing 1, 2, 3, 4. Are you guys getting better signal there? Okay. Mic check, testing 1, 2, 3, 4. Mic check, testing 1, 2, 3. Mic check. Mic check, testing 1, 2, 3, 4. Mic, ahora sí. Okay. Hello, hello. Mic check.
you're the only one I had not met. I'm Jorge Salazar. I will be the one introducing and moderating.
I was telling Juan, I'm hoping we could try to catch some time because I have to catch a 2 o'clock flight.
I see.
And have to return a car and put gas in it too.
Okay.
So,
how can I help in that?
well, I'm hoping that we'll be able to help you quickly.
I see. Okay.
If not, I may leave during one of the presentations.
Oh, I see. Yeah. Okay. Okay. Because if not, we might be able to get the understanding of the group that you go first or something like that.
Right, but even then for the Q&A.
I see. I see your point.
That's what I'm saying.
Well, I'm glad you're that conscientious, but you got to do what you got to do, Mika. Let me tell you, you're going far too. So.
Well, I think we just ran over and over. And
Yeah,
we
well,
haven't been able
and
to,
it happens, right? It's been great information.
Thank you.
Okay, we'll bear with that. And should we need to leave, by all means, do it at your discretion, and when I close up, I'll make the comment.
Thank you.
Could we have everyone come back to their seats, please? Could we have everyone come back, start to come back with our seats? I'd appreciate it. I know we have a lot of powerful information, and I know folks think about the information that's been provided this morning to date, that there's probably questions that will pop up. I do want to emphasize that by Tuesday morning, we will have all the information on our website. And if you picked up a packet, you'll see our website. It's www.lafayettepolicycenter.org. Pretty straightforward. www.lafayettepolicycenter.org. I would like to emphasize also, though we may get into it a little bit right after lunch, we will be communicating. We have all your emails, so we will hunt you down, okay? And you think we're not going to ask, and as Ann said, you know, things that we will certainly urge you to do. You started last night, Dr. Valdez gave you the personal number of the governor to call him. You know, I mean, so we will emphasize some high points on the website and correspond with you via the email and urge you again to join these coalitions, urge you to do certain things around your own representatives. And you know, my oldest sister lives in Plainview, and that's not my legislator up there, and that's one of the conservative legislators, or several. So I call her up, you know, Lola, me hace un favor, okay? So we can do that thing. If you got family in Fort Worth, you got family in Dallas, etc. You got family in Tyler, you know, ask them, give them a call, you know. Because as you know, representatives tend to listen a little bit more to the fact of their own constituency. So there will be some things that we will urge, and I don't want you to think that we're going to neglect that, along with our partners that have been presenting. I'm going to go ahead and introduce our facilitator and start our next panel. I would say that we may reserve our third panel, and I hope all of you certainly will be here. They came a long way, and the issue of immigrant health is not an issue that we're excluding. We feel all people should have access to care, and we will try to find avenues to make that happen prospectively. So we got some very good, talented folks with extensive experience, both nationally, statewide, and local, around immigrant health and the opportunities that we need to create. Because even the studies that were done here 2 or 3 years ago in Texas and nationally, they put in more money than they use. So anyone that tells you different, it's not correct. And that's well documented. That said, our facilitator, Jorge Salazar, is an administrator at our parent organization at Centro de Salud Familiar. He's had numerous roles there, and a major one for him right now, and he has for a little bit. Apart from being active with the coalitions and heading the coalitions around CHIP up in West Texas, the upper Panhandle, the upper Rio Grande, the counties in and around El Paso County. He's currently also the HIV AIDS director for the only comprehensive primary care services provided in one of the major health centers of Lafayette, serving El Paso and surrounding counties. So I'd like to introduce Jorge, por favor.
Gracias todos. Buenos días, right? Todavía? Good. We have a great line of presenters, and I think the backfall of yesterday's meeting with community and some of the great presentations we've heard already has set the stage to discuss now how some of these things are going to roll out, or we expect to roll out, and our panel are here with a level of experience to present what's going to be done or what can be done. Our first presenter will be Rachel Gonzalez Hansen, and introducing Rachel is introducing a friend. Rachel is the CEO of your local Community Health Development, Inc., a nonprofit community-based organization that serves the area of Uvalde, Real, Edwards, and parts of Zavala. She has been very active both at the state level, Texas Association of Community Health Centers. This is the group of community health centers that get together to discuss issues like this. And at the national level was the first Hispanic president of the National Association of Community Health Centers. And her list of recognitions is in your bio, but I think what she brings to the table is a real love of community and knowing what people need, because she's served at different levels of a community health center, and we expect that her insight will bring this together for us. She will be followed by Teresa Niño, and as I read her bio of holding such a distinguished position as the Director of Office of External Affairs and Beneficiary Services for the Center of Medicaid Services, the Department of Human Services. In other words, she comes from Washington and is one of the people that is going to help the President both interpret and hopefully make sure that these services reach the Latino and other communities. She comes with 20 years experience both in the political structure of healthcare, because her background is really in, as well as a reporter. But I think one of the things that caught my eye is how she's been able to maneuver from the public media meeting with the public to the policy level. And very appropriately named Niño, because it is our niños that are in danger right now of not getting their parents covered and their family covered through the expansion of Medicaid. And then we're going to have Courtney Watson come over. And, you know, Courtney, I had the pleasure of sitting at dinner with her and the other members of the Children's Health Defense Fund. And she epitomizes that saying of big things come in little packages. She's a really dynamic person that is going to go out there and help small businesses understand how this healthcare bill is really a strong economic development opportunity and an opportunity to provide coverage for so many people. So very different aspects, all coming with a focus, with a lens on how it's going to impact Latinos. And before we do this, I want to make sure that we understand that what makes this particular meeting, summit, important to us is that we're taking that lens that may not be taken in many parts of the United States, of focusing on what does it mean to the Latino population, that this morning awakening numbers of who we are and how many we are dictates that we do something. So with that, let me go ahead and introduce a dear friend and an advocate for equal access to healthcare, Rachel Gonzalez Hansen.
Buenos días. ¿Cómo amanecieron? Bien, todos alertos, echándole ganas a la lucha, ¿verdad? Siempre la lucha. Okay, so my apologies to the interpreters, because I'm sorry, I do go back and forth between my version of Tex-Mex and English, so, and sometimes speak too fast. So those are all my apologies to the interpreters. Sorry. So I want to thank Juan and La Fe and all of his staff and the staff back in El Paso for all of the work in putting this session together, this summit. It's certainly long overdue. And Juan and I were just commenting that it not only needs to be taken across the state, pero por toda la nación, ¿verdad? Throughout the entire nation. We need to be doing this and in a more powerful way. Ah, you're going to let me play with a toy? I'm not good at toys. All right, so let's start about what is a community health center. A lot of people will hear the term FQHC. FQHC stands for Federally Qualified Health Centers. Community health centers, most community health centers that are nonprofit and funded by the federal government are FQHCs. An FQHC is a payment methodology from Medicaid. And that's how community health centers like ours get funded by Medicaid or get reimbursed by Medicaid. So there's the difference between the two terminologies, and we'll go back and forth between the two terms, so just for your information. So let me tell you a little bit about community health centers, if you don't know. How many of you know community health centers? I think in San Antonio is Centro Med, quite a few. I want to say Frank Bryant, but it's Communicare. And Uvalde, it's Community Health Development, and we have them all over the state. So then I'm not going to go over it too much. It seems like most of you know. If you don't, then Google it. Google it. Google it. The most valuable piece of our model is our board of directors. Our board of directors are all volunteers. And by law, 51% have to be clients that we serve. No exceptions. Have to be clients that we serve. ¿Y por qué? Because they're the ones that are going to keep us focused. They're the ones that are going to say the mission. It's about the mission. It's not about you, Rachel, and your grandiose ideas. It's about the mission y la gente that we serve. And that is the value. And actually, I'm going to take a moment to introduce one of my board members, Francis Canales. Francis, if you would please stand. So Francis actually serves the farm worker population in our health center. She is a migrant farm worker. She also happens to have the distinction of being appointed for a second term by the Secretary of Health as a member of the National Advisory Council on Migrant Health. So, Francis, gracias for your work. And thank you for dragging your sister Lydia here, too. So, we are nonprofits. We are there to provide services to all. We are able to provide discounts to those that are in need. And so that's really important. That does open up for access, ¿verdad? It allows the people to come in and get access to care and not worry about whether they have money to pay for the services that day or not. If you're wondering about transparency, the word of the decade, ¿verdad? Transparency. Well, we've been doing this for 50 years, and we have always been transparent. We have always been able to tell you how our money is spent, how many people we employ. We have been gathering data for decades about the kind of difference we make in patients. Are they controlling their diabetes better? Ya no están comiendo tanta tortilla. Or more corn, ¿verdad? Are they controlling their hypertension better? Are they staying out of the emergency rooms? Are they staying out of the hospitals more? We have been doing that for quite some time. And so, yes, we are transparent. We do have reporting out reports that we provide to the feds, to the state. We could get state grants as well. And just to give you an idea of our services, this is why we are the provider of choice. This is why we are a healthcare home for the patients most in need. Because you can see those array of services there. That's a long list, right? Well, I'm not done. There's the rest of it. And some health centers go even beyond that, and I'll talk about that in just a little while as we go down. And we're going to go to that one. Nationwide, the health centers across America see over 20 million patients. That's a huge number, huge number. Of those 20 million, about half reside in rural areas. Over 34% are Latinos or Hispanic. We serve over 900,000 farm workers and over 1 million homeless. The hardest to reach populations. And over the years, we've been able to have significant growth, largely because we have had a lot of congressional support, bipartisan support, in Congress as well as the presidents. You know, they see the value of us. They see the value of the savings that we bring to the table. We're a huge economic impact with 140 staff around the country, over 30,000 volunteer board of directors, and over 8,000 sites that provide comprehensive care. Our patients are the sickest of the sick, and usually the poorest of the poor. We serve the working poor, we serve the farmers, we serve the ranchers. I'm talking about the ranch owners, not just the people that work in the ranches, but the ranch hands. We see people that are both Medicare and Medicaid coverage. Most of our patients are gonna have bastantes problemas. They're diabetic, hypertensive with chronic heart condition, and then they're coming in for infections, y qué sé yo. Okay, so it's multiple conditions. The value that we bring in addition to just doing the doctor's care is that we're gonna take the time to talk to the patient about how do they control their diabetes better and teach them and build their skills. We don't want them to be dependent on us as a healthcare system. We want them to take control of their condition, to manage their condition better. We want that disease to be controlled by them and not that the disease controls them. Two-thirds of the patients are minorities. Most of them, like we talked about, are likely to have chronic conditions. And 1/4, during 2011, 1/4 of all of the primary care visits of the nation's low income were at our doorstep, and we were taking care of them. We talked about our cost savings, how effective we are. Our total costs are 24 to 50% lower than those served in a private setting. That equates to about, those glasses, I'm gonna use this one, $24 billion annually of savings to taxpayers. So can you imagine if we're not there? And I remember that time when we weren't there in Uvalde anyway as a health center. I was a single parent with 2 children, and I remember the time when I did qualify for Medicaid, and then I didn't because I was $1 over. And regardless, though, back then, because back then we didn't have that FQHC rate that even some of the private doctors can get in rural health clinics, I still couldn't get in to see the doctor with my children because they didn't take Medicaid, right? So that was a problem. And I know a lot of you probably have been in the same shoes, ¿verdad? So can you imagine the savings and how far we've come to be able to help so many? I'm going to try to go through some of these just in the interest of time. There is an economic impact, as I've indicated, about us. Obviously, we are hiring people. We are hiring professionals at all levels. And we are in rural areas as well as frontier areas as well as in urban areas. In some cases, we're the only doctor in town. That's important because a lot of times in those rural areas, we're the only ones that have the larger number of staff. So we generate approximately $20 billion with a B dollars in economic activity for our local communities, producing over 189,000 jobs in places where there is a need, where the economy is very bad. And if you're wondering where we are in Texas, let me skip through that. All of those dots are service delivery sites. You know, we have 4 sites. There's health centers. I think there's Centro Med in San Antonio has, I don't know, 24, 25, a lot of sites. So this is where we are all over Texas. There's a few empty spots, right? You think we might need a few more in Texas? The answer was yes. Yes. Thank you very much. Very good. Oops. I think I went too far. Okay. We have some handouts at your table that Francis and Lydia were very gracious in helping me hand out, and I'm going to just point out to a few pieces. It's front and back. Grab the first one that's front and back, please. And this is about health centers in Texas. We talked about the affordable care that we provide to those that are underserved. 970,000 Texans are seen at our health centers. We are their medical and dental home. You can see some data there that's really important. 65% of our health center patients identify themselves as Hispanos or Latinos. That's a big portion, right? As we get older, I'm going to need to do eye care at my health center. So 28% of our patients have Medicaid. 51% are uninsured. 61% are at or below 100% of poverty. We are a good return on the investment. And we talked about that a while ago. In Texas, 7,400 full-time staff members and 115 billion, another B, in economic activity each year, no más in Texas, just in Texas alone. Medicaid dollars are 27% of the revenue that comes into our budgets. And if you look at our cost, look at this bottom corner right there. I think y'all can see that. That's the cost savings. Because we're the medical home, we take care of the patients with those full array of services. If that can't convince you that we are worth the investment, then you don't know what a sale is. This is better than the blue light sales at Walmart. Can you imagine that for every patient we see, every individual patient that we see, we can take care of them totally for less than $600 a year? Medical, dental, lab, x-ray, pharmacy, social services, getting them enrolled in Medicaid, getting them lined up with other services. That's pretty good. That's for the entire year for one patient on average. That's in Texas. All right, so what happens if that Medicaid and the cliff happens, right? Ah, yes, the cliff. We've been talking about cliff and that jump. I'm going to point you out. I'm going to guide you to the very last column on the top grid. And I hope that y'all can see this. If not, like he said, we'll have them out for everybody. But on that last one, that happens if we fall off the cliff at the federal level. If we fall off the cliff at the federal level, basically we're going to go from having about $2.9 billion nationwide to $1.4 billion. That means, in essence, that more than half of my budget will get killed, and I have one of the smaller budgets in our part of Texas. You know, I have an $8 million project. So more than half, that means definitely more than half of my staff, including doctors and dentists, will be cut. So can you imagine those that are out there that are seeing significantly more patients? We see 11,000 patients a year, individual patients. That's going to hurt. And there's only 30,000 in our area. So we're 1/3. Our patients are 1/3 of the entire population. So where are they going to go? Because they can't go to Mexico anymore. We're really close to the border. Pero ya no pueden cruzar. It's too dangerous. So where are they going to go? In Texas, it's going to be just as devastating, if not more, because in 2016, go down to the last column. The last column, 2016. I don't sleep at night. I worry about mi gente. But I guess this is why we're here, because Juan says that all of these people, all of y'all are going to help all of us, and we're going to get joined up in all those coalitions, and we're going to fight the fight. ¿Verdad? Another handout. Ooh, I heard a yay. That was good. All right, another handout that y'all have on your table, okay? Texas Health Centers and Medicaid. In 2011, Medicaid recipients made up more than 1/4 of all the health center patients in Texas. And you can see there their income, their insurance status of the patients that we see. In the most recent data, health centers served 7% of the Texas Medicaid patients. And as much as we get paid, it's only 0.5% of the Medicaid expenditures statewide. It's just 0.5%. Again, we're worth it. Valemos, ¿verdad? Texas Health Center revenues, you can see for yourself there on that bottom grid. If we lose the Medicaid, if we don't get that Medicaid expansion, and if we lose, by the way, we also stand to lose the way we get paid. Now it's called a PPS rate. You know how bureaucrats cada ratito cambian letras, alphabet soup, right? Well, the latest alphabet soup for how we get paid is PPS rate, prospective payment system. We stand to lose that without the expansion as well as with the cliff. And if we lose the Medicaid and we lose how we get paid, basically they have just killed the health center program. Even with the federal dollars, it's definitely not enough. Okay. So moving forward, obviously Texas plays, I think we've heard it, the message loud and clear. Medicaid plays an ever-increasing role in the healthcare for la gente que necesitan, ¿verdad? Necesidad here in Texas. And we need to make sure that we are there for them. Because I know I was one of them in the past. And I'm going to make sure that we're there for the rest. And the sad part is that even right now, under our current Medicaid system, We have over 1 million children that are eligible, and they're not enrolled. So I'm concerned about their health care, and where is it now for them? There's a couple of fallacies I want to get through here pretty quick here. Misperceptions. If Medicaid expands to cover 100% of all of those that are eligible, health centers aren't going to be needed. Well, guess what? I have health centers in 2 communities, and we're the only doctors in those two and a half counties. 2.5 counties. If you're in rural, you know what I'm talking about. If you've driven through parts of Texas, you know what I'm talking about. ¿Verdad? So guess what? If we're the only doctors in town and we go away, what's going to happen? So no, we're still needed. By the way, dental for adults is not covered under the Medicaid expansion. And everything that's in your mouth, think about it, everything that's in your mouth goes into your system and affects your entire body. So if we don't have good oral health, it doesn't matter about their medical health, because the oral health is going to kill us. From the time that you're a baby in the womb, you're affected by your mom's oral health. And it's not covered for adults. We need to make sure that that's in there. Medicaid will be, through the expansion, Medicaid will be available for adults, but it'll still have to be that they might have a copay. And how much is that copay going to be, and can they afford that? In our health centers, they'll be eligible to apply for the sliding fee scale for that copay. And are they going to let them do that in the private doctor's offices? No. And by the way, we've been seeing these people for how many years now? I said we had a 50-year track record. I know my children have been there their entire lives. By the way, they're still seen at a health center because they choose to be there. And they're adults because they know where they get the best care and they know where people care about them. And no, it's not at my health center because I'm the boss. They actually live in Laredo and in Fargo, North Dakota, and they go to the health centers there. So this is their healthcare home. Why would you change when you have the best? Again, another fallacy that because we had so much support that we have more and more money every year and we continue to get it. No, we don't. As a matter of fact, last year, we received a huge cut, and if it wasn't for the fact that in the Affordable Care Act, in Obamacare, health centers were a big piece of that. And so not only did they provide for health centers, but they provided a trust fund so that we could grow the health centers. They had to take the money, some of the money from that trust fund to put it into our appropriations to make us whole. Otherwise, I would have gotten cut in half. I know it's time. I'm sorry. I'm almost there, I swear. So I told you earlier we had a big array of services. Well, guess what we're doing now? You know that shift in population health that you sort of hear about when you hear all of the newscasts? We've been doing it. We have teaching kitchens. We have gyms. We're doing community gardens. You know, this is where people are coming to say, hey, I can help you grow some vegetables as well, you know, and we can share it around la gente que está pobre. And if they come and help in the garden, they don't have to pay, which is better than the farmer's market. They're helping to grow it, and they're helping to eat it. And then we're teaching them how to make it in a healthier way, right? We have to preserve the safety net. And there's several providers that are out there that are part of the safety net, but I can tell you that we're the only one that does all those array of services. We're the only one that are true medical homes for those that are the most disenfranchised. And we need to be here for a long, long time. So I'm joining the bandwagon with Juan. Where's Juan? I'm joining the bandwagon with Juan, and I'm going to be right there, and I'm asking the rest of you to be there because at one point or another, we all needed the help. We didn't get here because we were perfect when we were born and, you know, we had all these paths laid out with the golden brick and everything. We're here because we struggled through it, and we remember where we come from, and because we remember we need to give back. So I'm standing with you, Juan. Gracias for leading the fight.
Good morning, everybody.
Good morning.
Oh, that was, you got him trained well. Like everyone else, I want to give thanks to Juan and his staff for putting this summit together. This is a great opportunity to inform you of what's going on, not just in Texas, but also throughout the country in regards to Latino health. I'd also like to recognize some colleagues, Dr. Valdez and others from DC area. Also, I'd like to thank Dr. Rogelio Sainz and also Ann Dunkelberg, because their presentations cut mine in half. So, so I'll be able to just go through this a lot faster. So let me start out with when we talk about the uninsured on the national level, we're talking about 18.5% of the US population. I think you saw other slides that also made reference to this. That most of the US population has employer-sponsored insurance. That's 56.2% of the US population gets their insurance from their employer. The Medicaid population, you've been hearing a lot about that today, 19.8%. But again, the uninsured, for those individuals who may be working, but their employers do not offer them insurance, and you'd be surprised, some of them, like Walmart, has very low wages or puts their employees on a part-time basis, and this way does not have to provide health insurance to them. So these are people who may still be working, but are just don't have access to low affordable insurance. So in Texas, and again, you've heard these stats before earlier today, you have 6.1 million uninsured. 38% of the Latinos in Texas are uninsured. You have the Medicaid expansion is something that Texas has not declared yet, and I know we all can kind of guess where we're going with that. But in fact, today is the deadline for states to declare if they want to be a state-based exchange. And as of right before coming up here, we have 18 states that have said they want to be state-based exchanges, plus DC. And we also have 8 states that said that they will be partnership exchanges. And I'll get into the definition of those in a little while. But other things under the Affordable Care Act, or Obamacare, as you may have been hearing it, is some of the accomplishments that have been taking place already, like the young adults that are now able to be on their parents' health insurance, and something that's very close to my heart, the pre-existing condition insurance plan that has been able to help over 7,300 people in Texas. We also have, you've heard of some of the other benefits, as well as as all of the exams that you can now take that are at no cost, et cetera. And again, we saw some of these slides in regards to the census and where we are in regards to income, age distribution, uninsured, and so forth. So I'll just go through these very quickly, and more than anything, just really highlighting again that Latinos represent the highest uninsured population in the United States. We heard a definition of Medicaid expansion, and I just wanted to elaborate a little bit on it, because in addition to being that financial arm, we're also looking at, when people talk about Medicaid, it's not just a program for low-income families, but what happens a lot is that families ends up being women and children. If a single male is low income, he is not eligible for Medicaid. If a couple without children is low income, they are not eligible for Medicaid. So Medicaid expansion allows the eligibility to change and allows these populations, again, single males, low income, and childless adults that are low income, it allows them to be eligible. So we're looking at more people being eligible for the program, and also what you've heard before is that the federal government has said that for the first 3 years we would fund the program 100%, and after 2017 we would phase it down to 90%. So again, providing that support and assistance to the states so that they'll be able to implement this. And so when we talk about the Affordable Health Care Act, and when we talk about the state-based exchanges, there are really those two components. There's the Medicaid expansion, and then you have the state-based exchange. And what we're going to see also is very similar to Massachusetts, is a population that is just not going to apply for insurance regardless of how affordable or attainable it is. So these are the three different sectors that we see. We imagine 54% of individuals will qualify for Medicaid expansion. And again, these are the lowest income, the neediest families, the neediest individuals. And you see some of the income levels there. So this would be the Medicaid expansion in the blue. In the red is what we refer to as the state exchange portion of it. And even at that level, even though they wouldn't be under the Medicaid program, there would still be discounts and tax credits, and I'll go into those in a minute, that would be able to help individuals who are in this income bracket here, and this is calculating a family of 4. But when we look at families that make above that, we believe that about 10% of the population is just not going to go for health insurance. Again, when you look at Massachusetts that has this program for, over a decade now, they still have a 4% of uninsured. So even when these programs are in place, it doesn't necessarily mean that everybody's going to apply for them. I'm going to skip over this slide. So when I talk about the tax credits, we're looking at, for those families that come in just above the Medicaid eligibility range, you're going to be able, those families will be eligible for tax credits. And very similar to the FAFSA, how many of you are familiar with the FAFSA in education, the college loan part? Instead of giving you the money will go to the health insurance plan. So when you apply for the exchanges or for this reform, on the application, the federal government will determine where you fall in that. And if you fall above that line, the plan which you choose will receive the money so that what your cost for the insurance is going to be a lot lower. If you are on the upper range of that section, then there are other reduced cost sharing benefits, such as discounts on premiums or on co-pays or sometimes on some of the prescription drugs that would be a part of it. So again, a lot of different ways to be able to reduce the cost of health care. I mentioned the application, and this is something that's really very important because this is the application that whether it's a state-based exchange, a partnership exchange, or a federally facilitated exchange, there will be one application. And in order for us to really try to be more effective and efficient in the Paper Reduction Act and so forth, we are going to be doing this as an online application. So we're going to be really needing help in helping the people enroll into the program. The application will again determine where you are in the marketplace, which are the qualified health plans. If you qualify for Medicaid, Children's Health Insurance Program, CHIP, or some of the tax credits and cost sharing reductions that I mentioned. And this is also the one connection that we have to various federal agencies. So in association with the Social Security Administration, we would be able to look at eligibility as far as legal residency or legality of application in regards, and again with Homeland Security as well, and also with SBA and other programs or other federal agencies that we also work with closely. I mentioned that today was the deadline for states to provide us their blueprints for how they're going to be implementing their state-based exchanges. These are the other type of exchanges there are. The partnership exchange, we kind of call that the state exchange on training wheels because it really is helping states that want to implement the exchanges but just can't find the means to do it or don't have the means to do it, aren't really ready right now, but are interested in doing so. Some of those states, whether it's Idaho or I believe Arkansas is also talking to us right now about possibly being a partnership exchange. And also you may have heard in the news that some Republican governors, such as from Florida and Louisiana, are also talking to us about what are ways that, that they can approach this. And all along, we've been very, very flexible with the states to try to help them determine where they're coming in from, helping them at the level that they're coming in from to the program. In the first 2 years of the Affordable Care Act, we were providing grants to the states so that they could do research and planning for the exchanges. I will say that the state of Texas received a $1 million grant for planning the exchanges, and in December of last year, they returned $950,000 of it back and said thanks, but no thanks. So the partnership exchanges, they have a deadline of February. In February, we expect to hear what states are willing to do the partnership exchange. And again, there's a lot of negotiation going on right now. Federally facilitated exchanges are those states that don't do either a state-based exchange or a state partnership exchange. And we expect that Texas will be one of them. And I will tell you that that will be a very challenging situation for us because of the size of Texas, and also because, as was noted before, we cannot impose Medicaid expansion on a state. When governors talk about state rights, when they talk about that the state has the ability to do certain things, that's one of those things that the Supreme Court said it is up to the state if they want to expand the Medicaid program. So again, Texas would be very challenging for us to do. I will say that just recently, I believe it was yesterday, that New Mexico Governor Brian Sandoval did agree to a Medicaid expansion. And so New Mexico, which also has a high population of Latinos, of uninsured Latinos, will be going along with the Medicaid expansion. I'll say that the highest ones are California, Texas, New Mexico, Nevada, and Florida. Florida has about 36% of the Latino population uninsured. But again, Governor Scott has been talking to some, at some level with our folks. Consumers and small businesses, nonprofits also will have the ability to refer their employees to the exchanges because this way they'll be able to do some of the comparison of the different plans there and choose some lower plans. And enrollment will start as early as October of 2013. Coverage will actually start January 1st of 2014, but we're going to start enrolling people in the exchanges, whether they're state-based exchange or federally facilitated exchange, starting October 1st of 2013. Some things that are very critical for us right now, and I should also point out that there are handouts from my office in the back of the room that have several links to what the application will look like right now, what some of the blueprints from states look like, so you could see what other states are doing in regards to implementation. But when we talk about applications starting in October, we're looking at really providing consumer support. Very similar to the Medicare program, we envisioned a 1-800 number and a 24-hour toll-free number that will be available in, with operators in various languages. We expect about 10 to 13 languages. Internet website with chat capability. And the internet website will be bilingual, Spanish and English. We won't be able to take that into the 10 different languages, but it will be bilingual. And also navigators and other in-person consumer assistance programs. Texas does have a consumer assistance program, again, funded by the US government. And these are centers at the state level to help people with determining where they are in the exchanges, helping them understand the whole process. Keep in mind that this is an uninsured population, so in addition to this, all this news about exchanges and Medicaid expansion, you know, we're also talking about people who aren't familiar with some of the terminology. And I could tell you that those 56.4% of employer-sponsored people that have the insurance through their employer, they get confused at times in enrollment between premiums and what's the deductible and comparing plans. And You know, sometimes they'll go for the cheap plan that has the high deductible, but when you need the service, then you find that you have to pay this high deductible out of pocket because you wanted something cheap to be paying monthly. So that health insurance literacy training is something that we're also going to be needing to implement, as well as culturally linguistic and appropriate services, which is part of the Affordable Care Act, in order to be able to provide services in the language and in the culture that people need it in. I'll focus a little bit more on navigators and the Consumer Assistance Program, because that's somewhere where we're really going to need a lot of local and grassroots help. I mentioned that grants have been provided to the states for the consumer assistance programs, and these are some of the things that they'll do is educate consumers, identify and enroll, and also assist with filing complaints and appeals, because we do know that there's going to be a lot of predatory practices going on out there, unfortunately, but this is what happens when a marketplace opens up. The marketplace navigators. This is really key because HHS will have grants available for groups who can train, educate, or help people with the enrollment process, with the education and enrollment process. You see some of the responsibilities here. Well, in June of 2013, the Department of Health and Human Services, particularly the Centers for Medicare and Medicaid Services, will be putting out these grants for people to apply for them, well, I should say groups to apply for them. And for state-based exchanges, let's say if I were giving this speech in California, I would be saying that we give the money to the state, and the state is the one that puts the grants out. But part of every blueprint or every plan that's been submitted requires some description as to how they're going to actually enroll people into the program and how they're going to run their programs. I know someone else will be talking about the small businesses, so I'll leave most of the details to that. But as I mentioned earlier, small businesses and nonprofits will also be able to tap the exchanges. And I'm leaving this slide up here. We have a regional office in Dallas, the Centers for Medicare and Medicaid Services. And not only are they for Texas, but also for the 5-state region in the area. So that is the information. Renard Murray is the regional administrator for our Dallas office, and can answer questions that are more detailed to Texas. But thank you very much for your presentation, or for this talk.
Oh, can everybody see me over this? First of all, I want to say thank you very much to LaFay and Juan for having me here, and for everyone. I think this is a really great opportunity for us to come together and really get some ideas going and learning what we can take back to our communities and take to our legislators. So thank you for coming and allowing me to come and speak. I am a healthcare organizer with the Children's Defense Fund of Texas, and my colleagues are sitting over there waving, and this one's over here taking a picture of me. And the Children's Defense Fund is a really great organization. My slide. We have been in the field for over 40 years, helping children have a voice and be able to help them have a healthy start in life. And we have offices all around the country. I am personally a small business owner myself. My husband and I have a car detail manufacturing business, and so I feel that I take this very personally as a small business owner. We've partnered with a, sorry, I'm not used to this. We've partnered with a small business majority, which is an advocacy organization that was founded by small business owners, and they focus on outreach and education to small businesses and all across the country. They do research and advocacy on the top issues that they have found have been access to credit, clean energy, but most importantly, healthcare. And you may ask the question, why is CDF, the Children's Defense Fund, worried about small businesses, and why are we interacting with them? Well, probably if you're not a small business owner, you may be an employee, or you know someone who is. And these people have families, and these people have families, have children. And we know that when the parents are enrolled in healthcare, more than likely the children will be enrolled as well. So we found this to be really a great avenue to do some advocacy on the behalf of children. We also know that small businesses are the backbone of our economy. And so it's important that we go and we teach small business owners about the Affordable Care Act. And you will hear me refer to this as the Affordable Care Act. Many people refer to it as Obamacare. I would, just my personal opinion, would discourage calling it Obamacare, because when you go and you're talking to folks who are not, an advocate for the president, then it's all automatically kind of gives them that negative feeling. So when you're speaking to your legislators, when you're speaking to your coworkers and your family and friends, I would use the Affordable Care Act as just the way to go about it. But what we're finding is small businesses are struggling with healthcare costs. It's been soaring within the past 10 years, more than we've ever seen. And over 25% of our small business owners are uninsured, including 28% of self-employed people are not covered as well. And what's really frustrating is that small businesses pay, those who do offer healthcare insurance, pay more than 18% than the large businesses do. We asked the question to small businesses when we did our study about why are they not offering it? What is the the best reason, that the main reason that they don't do it? And the main reason is they can't afford it. We have learned that at least 70% say that lack of affordability is the main reason. This is just another slide to show a little bit about the question. Another survey found that over 72% of the small businesses who do offer it are struggling to do so. The prices are just going up continually, and the ACA will help put a stop to this because of the competition that will be available to folks within the Small Business Healthcare Exchange, which I'll get to in just a moment. We are working on shared and individual responsibility with these exchanges. Businesses with fewer than 50 full-time employees, which is 96% of all businesses, are exempt from any requirement to offer health insurance. So when you're in, you hear from the media, there's been a lot of mistruths out there, and people are worried, my whole business is going to go under. Well, like I said, 96% of all businesses have 50 or fewer people, and you're not going to be required to offer it. So just take that off, and those, we still want to encourage people to offer it, but we don't want people to get the idea that they're being forced to offer something, especially if they can't afford it. I want to just touch briefly on the key provisions about how the ACA is going to affect the small businesses. And basically, it's going to provide an immediate tax credit for most small businesses. Just a moment ago, someone spoke about the pre-existing condition insurance plan, and this is going to provide immediate access to folks who are individuals and the self-employed. the way you qualify for the program, and this is available to folks now. So if you know someone who's uninsured, has a pre-existing condition and desperately needs health care, this is an avenue to go to, and it's pcip.gov is the way to find more information about that. But basically what the SHOP Exchange, the Small Business Healthcare Exchange, is going to do is it's going to create competition in the marketplace. It's going to make it so that the prices are more competitive, and it's going to make competition among small businesses better, because those small businesses who offer health care, those are the folks who are going to be able to have the widest variety and the best pick of folks to employ. Now, the small business tax credits is a very important part of, I think, speaking to small businesses about why this will help them. It's available now. If you are already offering health insurance to your employees, you can go ahead since 2010 and start taking the tax credits. It's available to businesses with employees, and which businesses are eligible? Those businesses with fewer than 25 employees are able to get the tax credit if they have an average annual wage of $50,000, which is very common among small businesses, and the employer must pay 50% of the premium, which is a basic practice among businesses in general, as it is now. And in addition to the tax credits, oh, I went too far. You'll be able to see, this kind of gives you a picture of the small business tax credits. And in Texas, we have over 248,700 businesses that are going to be eligible for some tax credit. That's over 80% of our small businesses. If they offer health insurance, will be able to take part in this credit. Out of those 248,000, you're going to find that 79,000 are available for the maximum credit, which is 50%. For the rest of the folks, they will be able to at least get the 35% that's available to them. Sorry, I'm a little bit behind on this. Just a little bit more info about the tax credit. It's done on a sliding scale. So up from 2010 until 2013, if you choose to do the healthcare, you can get a 35% tax credit on your premium. Beginning in 2014 is when the tax credit will go up to 50%, and that will be available for 2 years after 2014. The tax credits do not cover their owners or their employees, or their families, and the tax credits cannot be claimed by the self-employed. That doesn't mean the self-employed are going to be left out. That means the self-employed are going to be able to be a part of the individual exchange, which we just spoke about earlier. And even as an amendment that was done, you can, if you decide just now, okay, I want to start offering healthcare, or I have been offering healthcare, and now I want to take advantage of these tax credits, you can grandfather that back until 2010 and actually use those for the first 2 years if you decide to do so. Now, just on a practical level, I have a lot of small business owners that are like, well, how do I do this? How do I start to take part if I want to figure out how it's going to affect me? Small business owners who are business or tax exempt will use a form called an 8941, and it's available on the website irs.gov. You can download that form and fill it out. Small businesses will include the amount of the credit as part of their general business credit on the income tax returns. The credit can be reflected in determining estimated tax payments for a year, and the credit, it's important to note, applies toward the income tax and not the employment tax. So when I'm speaking to small business owners, they like to know kind of the practicality of how am I going to use this, and how can I make sure I'm doing it correctly. Now, I really like to talk about the exchange, the State Health Insurance Exchange, which will be starting in 2014. It's going to basically create a large marketplace among small businesses to be able to shop for healthcare coverage. It creates a purchasing pool that is going to be spreading the risk So it's available for health insurance companies. That gives them a little bit of a lift to be able to say, okay, if we're all going to come into this pool and all these small businesses decide to offer health insurance, they're going to be a part of a pool that's almost going to operate like a big business, which spreads the risk for them. So the more people, the more small business owners, the more small business owners that do decide to take part, the better off we all are. Small businesses with fewer than 50 to 100 people are eligible to take part in the exchange. That also means that private insurance plans will compete, which will be able to make sure the prices stay a little bit regulated and you're not going to see premiums go up in amazing ways. And it helps the employer be able to have more choices. And what's a really important thing, I think, to note is that the health insurance exchange can negotiate with insurers on behalf of the small businesses to even try to get lower rates and higher quality. So we'll be able to have an advocate on small business owners' behalf. I really want to just take note quickly of the RAND study that was done, which says that the exchange that I'm speaking about right now will expand coverage to 85.9% of small business owners. That is up from 60%, which is today. So we're increasing over 10.5 million workers to be able to now provide health insurance. And that means they can now buy it for their family and for their children as well. How is this exchange going to work? It's basically a web portal. I don't know if you've ever tried to buy a flight on like kayak.com or Expedia. It's very simple. You can compare the plans. They're laid out with detailed information that is easy to understand, not a lot of insurance jargon, but it'll give information about price and quality and service. The plans are going to be organized on precious metals, so you can decide, I want the bronze. I don't want a deductible, but I'm willing to pay higher premiums for that. Or oh no, that's the opposite. If I want the platinum, if I decide to do that, then I don't want to have to pay a big deductible. The bronze, if they decide, I don't get sick very often, I think I'm going to be okay, but I still want this for myself just in case, then they can have a higher deductible. So they have choices among this within the exchange. There's a calculator that you can compare cost to plan options whenever you go on this website, and they'll be streamlining the billing process so it makes it easier for the folks who are small business owners that don't just have an HR department, which most of them that don't. So it makes it easy for the business owner to be able to do this. Let's see. Just quickly, just to point out a few things, this is the insurance exchange is going to ensure that more money goes to medical care, so it's going to reduce the administrative costs. There's something called an 80-20 rule, where 80% of your premiums, say you pay $400 in premiums, 80% of that money has to go towards your health care. No longer can they just decide that they want to take a big bonus and take a huge part of your premium out. 80% must go to your health care, and only 20% can go to overhead and administrative costs and bonuses that they decide to give out. It also offers incentives of administrative efficiency and modernization. The exchange, the states decide whether to keep the individual and small group markets separate or to merge them. The insurance will be still sold outside the exchange. So if you already have your health care, you don't want to change it, you don't have to. That's a really big myth that's out there. And what I love the most, and when I go and speak to small businesses, this seems to be something that really excites them, which is that members of Congress will have to take part in this exchange, including their staff. So there's no, I'm going to get the better deal from the regular Joe Schmo on the street. Just quickly, I think it's important to touch on what Rick Perry, we've talked a little bit about the governor and what he said. He did say we're not going to take part in the exchange. He did say, no, we're not going to take the Medicaid expansion. But you know what the good news is? It's not up to Rick Perry. It's up to us. It's up to us. It's up to our legislators. And it's up to us to be able to go and speak to them and speak to our neighbors, speak to our coworkers. Just real quickly, I'm almost done. There's also going to be a rate review process, which I don't think we've touched on. The rate review process means that the insurance companies are required to disclose and justify any rate increase over 10%. Many of us have paid our premiums, all of a sudden it's gone up $100. No answer why, no explanation. Now they will be having to post on the healthcare.gov, and each state's review program will give customers a chance to comment on the explanations. Right now, Texas does not have a good rate review process in place. The Texas Department of Insurance doesn't have any teeth. We're going to be going to the legislator this session to tell them we need the Texas Department of Insurance to be able to say, no, you can't raise it more than 10%. That will be a huge help to us. What do we need to do to make the Affordable Care Act stronger in Texas? We need to stop the unjust rate hikes, which I just mentioned. We need the Medicaid expansion, which even though the governor has said no to, it's not his decision. That means we have to go and speak to our legislators. Doctors need higher reimbursement rates for treating patients on Medicaid. That's very important. Our leaders, Medicaid works in other states, by the way. It works very, very well. If you have leaders who don't believe in Medicaid because of ideology and they're going to place that over practicality, then it's going to fail. They're going to purposely set it up so that it's not implemented well and there's holes in it. And we have to make sure that we take part and we let them know that we're demanding that. We also need to expand the scope of practice for nurse practitioners and other medical professionals because that will definitely help us in the long run. Quickly, I want to just give you the state and national resources that are available. Healthcare.gov is an excellent website to get basic information and detailed information as well. You can go to our website, cdftexas.org, or the smallbusinessmajority.org. They have a really great slideshow that's on what's healthcare reform for small business. They have a detailed FAQ for small business owners. And even more important, they have a tax credit calculator. So it can really help them understand how much am I going to be paying and what are my tax credits going to be. Quickly, contact information. Please jot this down. Part of my job is to go out and speak to groups like this, except really with a focus on small businesses. So I go around, I speak to chambers, I speak to Rotary clubs, and if you are a small business owner, you're involved in a network that has small businesses, then please, please contact me. I was in West Texas 2 weeks ago. That was interesting. I'm going to East Texas, which is where I'm from, and I'm ready, and I'm used to going into enemy territory, as you can say sometimes. Folks who don't support it, but by the end of my presentation, I did have people come up to me and say, you know, I'm really upset because I didn't know half of this. And the reason they didn't know half of it was because all they heard was rhetoric. And that's why it's important for folks like us to get out there in the community. So please contact me, especially if you're in the Rio Grande Valley, El Paso. I really need some contacts there. So please get in touch with me about that. We're also doing a Medicaid Story partnership, and I know many of you are part of an organization that deals with clients who are on Medicaid. And if you are, please contact me because we're going to try to take testimonies and stories to the legislature and try to get them to testify, maybe do a video. So if you are a part of a clinic, deals with Medicaid patients, please take down my information. C. Watson at childrensdefense.org or call me direct on my cell, 512-788-1301. I've got handouts over there, and I'm really sorry I took over a little bit more time than I should. Thank you very much.
We have a few more minutes, and we're going to take a few questions. So if there's anybody that'd like to ask a question for anybody on our panel, I'm sorry, Teresa Nino had to leave, and so she won't be here, but anybody?
My question is actually for Courtney. Are you building coalition groups to do this work? I just feel like a lot of everything we need is these small business owners in the Capitol kind of really making the headway. So do you have coalition groups we can put folks in touch with, or how are you organizing that?
I'm with the Texas Well and Healthy campaign, and so that's a coalition that we're working on. And I'm kind of working on building an arsenal of small business owners that will be able to call. So if you know of a small business owner that supports the Affordable Care Act, then please put them in touch with me, because these are the folks that are, and let me tell you, especially in a very conservative place where we live, small business owners are the ones that the legislators listen to. And so we definitely need to have them up there advocating for the Affordable Care Act and saying, I want to take part in this.
Anyone else?
Thank you very much.
Oh, hold on, back here. Oh, a phone number.
Area code 512-788-1301.
And just a reminder, we will be sending you these PowerPoints. And so obviously there were probably like over 100. So we really weren't going to print them out for you, sorry. But you will be getting them once again.
And like I said, I do have information in the back over there, or you can come see me and talk to me. Thank you.
Thank you.
I'm sure that by now you see the thread of advocacy throughout from yesterday to today and what we need to do. And certainly there's a lot of work with us ahead for us. What we're going to do now is I'd like to introduce our keynote speaker here for lunch right before we step into lunch. And then we'll have our panel following that. And one of the things when we started, and when even this morning, and having the translators here, it never ceases to amaze me how we often forget about the importance of language and communicating, and how are you going to have folks informed and educated to these issues if we don't take the time to do that. Then the other aspect, which I wanted to thread at least a little bit, is media. You did hear some comments, if you will, like, for example, from Dr. Sines, referencing, you know, the kinds of things that happen out there a little bit in media in terms of how we may be portrayed. So I wanted to take an opportunity at least to have a little bit of our agenda, because media is important, communications is important, and how we use that media effectively to both frame our messages and frame our values as it relates to these issues we're discussing and their importance. We need to have that on our radar, and we need to develop those skills and those relationships with media or communications to do it effectively. With that in mind, I want to introduce Dr. Federico Severin. He is a full professor and director of the Center for the Study of Latino Media and Markets at the School of Journalism and Mass Communications at Texas State University in San Marcos, my old alma mater when it used to be called the Southwest Texas State. Since the early 1980s, he's had been conducting research, publishing, and teaching on a broad range of issues related to the mass media and ethnic minorities, especially Latinos in the United States. He is the editor and author of the book, The Mass Media and Latino Politics, Study of the U.S. Media Content, Campaign Strategies, and Survey Research. And it's my privilege to have met him a couple of years ago now and got involved with him and a group of other researchers, where how can we take that information coming out of good, effective policy research, and how do we cross the bridge to utilize media to translate that research for us on the ground in a way that we can make our public officials listen. And again, that in itself is a challenge. So I probably introduce Dr. Severin.
Golly, I'm the guy in between you and having your lunch, and you're all hungry. So what I've decided to do is change this presentation from a big, long slide that I had, and now I'm going to address you as if you were my students, and I'm trying to convince you of something that you're going to be learning after class and get a pop quiz about that. First thing that I always say when I talk is that I'm from Puerto Rico. Anybody here from Puerto Rico? Hey, qué bueno. Okay, at least someone else. because it's part of our national heritage and our ethnic heritage to be, and I'm proud of it. So, question, how many of you have a media plan with your organizations? Just one hand, two, three hands, four, okay. Because that's the point. I've changed this whole thing. Let's see if I can get something. If a tree falls in a forest, and you know the rest of it, right? Okay, so what about this other one? If flowers bloom among the weeds, but nobody sees the flowers, are there flowers there? Like, you know, flowers among the weeds? Yes, there are flowers there. The problem is that many people are not looking for those, and the flowers are the ones that you're developing in your organizations, and they may be in the desert, but they are there, and we have to learn how to reach out to them. Now, the weeds are the repeated stereotypes, lies, negative images, and all of these bad things that we already know about us in the media. The flowers, oh, and then TV, radio news, and nowadays even the internet and the video games. Anybody seen the video games with Latinos as the targets for shooting? They're out there. So we have to deal with all of those. Now, how we deal with those, and that's where I'm going to stop all of the rest of these. Let's see. Yeah. There are 4 conditions that maximize how media affect us, and that's repetition, dramatic images, perceived relevance, and frame of reference. I'm not going to go into that because I'm going to leave it back here with the one about the flowers and what to do. And here's the 3 points for the pop quiz at the end of the lecture, of the talk. Number 1, if you don't have a media plan, you must have one. And if you do have a media plan, the first thing is, do you have an assessment of the media in your communities? I'm talking about all the Latino-oriented media, and, well, even some English language media. Do you know those media? Do you know where they are when they publish, how often they get out? What are the criteria for them to get your news, your information out? If you don't, you have to learn that very quickly, because otherwise you will be speaking in the, you'll be the tree in the forest that nobody hears because they don't know that you're there. Or you'll be the flowers among the weeds and people are just confused with the weeds and they won't be hearing what you say. What are their schedules? What are their deadlines? Who are the key decision makers in each of those places? If you don't know them, learn them. And you learn them before, not just the day that you have your event, that you, oh, we have to get this press release, and let's see if let's send it to the media, and they'll take it and they'll look at it and say, we don't know who these people are. And by the way, it's in English and we publish in Spanish. ¿Por qué no lo tradujeron? Para que lo pudiéramos usar sin tener que traducirlo nosotros. You all got what I said. So if you don't have it both ways, you'll be limiting how your tree falls in the forest and makes a big sound, or your flowers won't be heard out there. The second point is to learn how to reach them and to publish and how to get across your message directly nowadays using social media and the internet. If you don't have a website for your organization, make sure you do. Make sure you have a space that's in Spanish too, that you have your press releases, that you have your information. And here's another part. Have you learned how to talk to television? Have you learned how to have those 20-second sound bites? That is at most what they will use when they speak to you in English and Spanish. If you haven't, you must, because otherwise, like we had Telemundo here today, and they've been taping a lot. Guess how much the maximum they'll be able to cover this evening in the news? At most 2 minutes, 3 minutes. Is it your message or their interpretation of your message? So you have to create your interpretation that you want to get across, and you have to have that ready. If you don't know how to do that, look, there are lots of students in public relations in our universities who are eager to be interns for you. And some of them are very good in being bilingual. And they'll help you with your plan. They'll practice it. You can use their cameras, the school cameras, the university cameras that they have to tape you giving a sound bite, and you can look at it before it's on TV that evening. Use them. They'll practice it. They'll learn how to do a better job themselves when they're doing that. They can practice doing their press releases, their media plans for you, and you learn from them. When they're gone, well, you might be able to hire them if it's good, if it's paying off for you. So train yourself and your staff to get your messages out so that you'll be the flowers, you'll be heard everywhere and not be surrounded, not be drowned by the weeds. The third point and the last one is to get your boards to advocate for you with those media. Those media will not come to you if they don't know you, but they may know your board members, your advisory members. Use those chambers of commerce I heard mentioning before. Those Latino chambers of commerce can be the ones to get those messages for you. Folks, this is on health issues. My research has been on Latino media and politics, but also I've been involved in research about emergency communication. If there were emergencies, we have gaps, and this is one of the titles of the gaps that I was going to get to, but because of the time constraint, I'm going to cut that. I've cut that part of the presentation to mention something. When I pointed out in my first issue about getting to the media out there, how many radio stations that air in Spanish in Central Texas have news departments? Can anybody tell me? You know what the number is, right? 0. So what happens when there's a major fire, a sudden fire, or there's a train derailment? In terms of people who are listening to Spanish language radio to know what to do, where to go. If there's an epidemic, something happening, where do they go? Well, it's on television, but only if those emergencies happen Monday through Friday, 8 to 5 p.m. Remember the Bastrop fire, September 11th last year, September 10th last year? Okay. Because it happened on a Sunday, and none of the radio stations have any news, and Univision and Telemundo, at least in Austin, don't have news departments, people found out about them in Espanol on Monday. Kind of too late for some folks. And they started learning about that kind of very trickling in English on one station. We don't have in our communities the media outlets. We have to create them with social media, new media, smartphones to get our messages out. Because we want to be the flowers in the desert, but that everybody sees them and they know that you're there for your communities, but for that you have to be prepared. Our Center for the Study of Latino Media Markets could be of assistance. I can be of assistance. Let me go back to the first slide. Just in case you missed getting my information there, it's right down there. That's the home office number because we're in recess now and I spent more time at my home office than at the academic office. I live in Austin and I travel to San Marcos for classes and meetings and for the center. But I can be reached there. You can reach me by the emails, wherever at texasstate.edu anytime. And we'll guide you or we'll have our students help you in getting out your messages. Create those media plans, develop your staff, and get the word out about your plans because you are the flowers in those deserts among the weeds that need to be known, recognized, and celebrated. Thank you very much.
Can I, really quickly, if there's any questions, we can take a few and then we're going to go into lunch. Any questions? One back here. Did you get it going, Carlos? Okay.
He's excited he got a question, he said. What makes a good 20 sound bite? What typical information would you need in order for it to be effective?
An actionable point. Something that people will understand easily without giving all the context. An actionable point. Go to, vayan al centro, llamen a este número, find this number. We are here to serve you. This is what we do. We do 3 things, 1, 2, 3. That comes out in a 20-second soundbite. Rather than there's a big need for the concern, for the community, it's growing, it's developing. That's great when they interview on the Sunday morning shows. But for those sound bites, like why are we here? Because why are the reasons? Do we have the sound bites? Do we have the press releases for the press to come in here? We're here because we want to educate the community about the needs, the new laws, and we have places to go. Find us here. 1, 2, 3. That will come out in their 20 seconds. Folks, I teach journalism. I'm not the journalism professor. I teach journalism students. And many other my colleagues teach journalism students. And they're trying to do a good job. But they are all over the place, and they're not focused on your message. You have to guide them to be focused on your message. And that's a good soundbite to make it quick and simple. Like the first part of what I said, not everything else that I said after, to answer your question, I elaborated on it.
I have a quick comment. You know, I think that as we think about healthcare and framing, during, you know, the whole fight for healthcare reform, the framing actually was, you know, really challenging because there were so many messages out there. And in particular, getting voices and particular stories, as we said throughout, have been very challenging from the Latino community for us to get them out there. I think this past election, we seem to hear a little bit more, especially with the decision from the Supreme Court. Can you tell us a little bit about what you feel that the frames have been so far as it relates to healthcare and Latinos, and if you think they're adequate?
They're not adequate is the answer to the last part, because the framing has been as Latinos have been framed in most news stories. I didn't get to the slide where I point out. We've done content analysis of how the network news and even some local news cover Latino and Latino issues. So what do you think are the number 1 and number 2 topics of these media news about us? Number 1, immigration. Number 2, crime. Or Latinos committing crime that deals because of immigration. It's a combination of that. That's 60% of the news about us. What are the images about us in entertainment media? The maids, the criminals, and all of that. That's the frame that they have about us. So when it comes to healthcare, these are people who are needing us, and they're going to drain our limited resources, most of them illegal, by the way. So they're going to drain our limited resources, not that they are part of the community. And one of the other slides that I use for emergency communication talks states the following. Like the chain is as strong as its weakest link, a community is as safe as its least informed citizen. Now translate that to health. A community is as healthy as its least healthy citizen, because one unhealthy person affects the others. We have to present that frame that everybody needs to be healthy. The other frame that I use in talking about emergency communication is that some people will say, well, why don't they speak English? And I say, you know, I don't know any Latino who doesn't want to learn English. It's just that they're busy in 2 and 3 jobs. Some of them have generational issues, whatever it is. But you know what happens? That when tornadoes come, they don't select the English-speaking areas. And the floods don't go only to the English-speaking people because they're okay. And the fires don't say, well, let's go to the English-speaking people. And the chemical spill doesn't say, let me get the truck to the other side where there's the English-speaking people. They'll know what to do when there's the spill. It doesn't happen that way. So everybody needs to be informed, and everybody needs to be cared for with health for the health of the whole community. That should be the frame, because everybody's healthy when we are all healthy. And those are little frames that contribute to that process.
All right, is there any other comments? So I think how we're going to do this today is...
Thank you very much.
Thank you. We're actually, lunch is a box lunch this afternoon, and it is located in the same place in where you got your breakfast. And so what we're going to do is we're going to have everyone go and get their box lunches and get a few minutes to chat amongst each other, because I know that we have, you know, obviously with a really tight agenda, not many of you have not had an opportunity to connect with your own table mates. So we're going to do that for a few minutes, and so don't leave. We have a really exciting panel, Immigrant Access to Care, which is a very fundamental questions and discourse we need to be having for today. So thank you.